Hello, 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 hello.
Good morning, everyone. A very warm welcome to our distinguished guest, honorable speakers, faculty, professors, postgraduates, and all the delegates who have gathered here today. I feel extremely glad to welcome you to the CME on the recent advances in the management of carcinoma breast, organized by the Department of General Surgery, Narayana Medical College, Nellore. I'm Dr. Sudeep, junior resident, and it gives me immense pleasure to be standing in front of you all. Before we kickstart the CME, I'd like to express my gratitude towards all of you who contributed to this event in order to make this a success. This wouldn't have been possible without the support of each and every one of you. I take this opportunity to extend my heartfelt invitation to our beloved dignitaries who have taken the time to grace the occasion. First of all, I'd like to invite our Honorable Dean of Narayana Medical College, Dr. S.P. Rao sir, to the gathering. Welcome to the gatherings. Now I would like to invite our beloved medical superintendent, Dr. Hariprasad Reddy Garu, to the dais. I must mention our deep sense of invitation to the MS of Red Cross India Cancer Hospital, Dr. Nageshwar Rao Garu. I heartily welcome to the dais, sir. Let me use this opportunity to call our Dr. Sampas Kumar sir, Professor of Department of General Surgery, to grace the occasion. Up next, I would like to welcome Dr. Videsh Lingam sir, Professor of General Surgery, to grace the occasion. I would now like to request Dr. G.V. Prakash sir, Professor of General Surgery, to come on to the dais. Yes. I now welcome Dr. Mahendra Reddy sir, Head of Department of General Surgery, to come out of the dais and join the meeting, sir. Thank you for making this event, sir. With this warm and affectionate felicitation, we'd like to give a sweet and musical welcome to you all. Without any further ado, I'd like to call upon Dr. Meghna, one of our house surgeons, to begin today's proceedings with a prayer song.
भावयामि गोपालबालं मनसेवितं तत्पदं चिन्तयेयम् भावयामि गोपालबालं मनसेवितं तत्पदं चिन्तयेयं सदा निरतकर कलित नवनीतम् ब्रह्मादि सुरनिकर भावना शोभितपदम् तिरुवेङ्कटाचलस्थितम् अनुपमं हरिं तिरुवेङ्कटाचलस्थितम् अनुपमं हरिं परमपुरुषं गोपालबालं भावयामि गोपालबालं मनसेवितं तत्पदं चिन्तयेयं सदा. Thank you.
Such beautiful vocals. Thank you, Meghna, for your song. Now we'll have our lamp lighting ceremony as a tribute to Mother Saraswati, the deity of knowledge. May the darkness of ignorance be swept away by the dawn of self-realization. I request all the dignitaries to please participate in this auspicious ceremony. Moving on, we now request our beloved Dean of Narayana Medical College and Hospital, Dr. S.P. Rao sir, to address the gathering.
Good morning to all of you. First, let me congratulate the Department of Surgery and Dr. Mahidhar, who took initiative to organize this program. As I understand that the fourth paper in almost all MD, MS courses is based on recent advances in the particular subject. And as you all know, when we were students, we were told that carcinoma cervix is the leading cause of death or the leading cancer among women. But over the years, the breast cancer has taken over, and now it is the first leading cause of cancers among women. And you'll be surprised to know 1/3 of cancers that were detected in women belong to carcinoma of the breast. So it's sad that we should know more about this carcinoma of the breast. If you see the national program of cancer, government is more focus on pap smear and carcinoma cervix rather than concentrating on carcinoma of the breast. As the topic says, it is the management. I go beyond the management. Before coming to management, how can we prevent the cancer? So the first and foremost is SBE, self-breast examination, which we don't give much importance when we are dealing with women. And as you see, most of these breast cancers are reaching the peak after 40 years. So at this age, whenever a woman comes, and that's an opportunity wherein we can educate the woman regarding the self-breast examination. So thereby we can prevent the development of cancer. If you see the management of cancers in hospitals, most of them are beyond 2B. So it obvious that we are unable to detect them in the early stages and leading to various complications and disability and deformity. So it's good that the respected speakers and experienced people have come here to make you aware what is happening in breast cancer. And I'm also happy that there's a training session in the afternoon regarding the detection of breast cancer in a simulated environment. Once again, I congratulate the Department of Surgery, which is filled with experienced people. And I hope all the participants will be able to gain insights into the recent advances of carcinoma of the breast. Thank you very much.
Thank you, sir, for your kind words. Next, we'd like to call upon our medical superintendent, Dr. Hariprasad Reddy Garu, to speak a few words for our delegates.
Good morning, all of you. So I'm happy that all the departments are coming up with the CMEs, and I'm glad that the Department of Surgery, under the leadership of dynamic leadership of Mahidar, and with the able guidance of the seniors, so they come up with this wonderful CME on the workshop on the recent advances in the management of breast cancers, both surgical chemotherapy and radiotherapy, recent advances, and followed by workshop on the true cut biopsy in the afternoon, hands-on. So the program is very well designed, and as the postgraduates, so they have this wonderful opportunity to learn the recent management techniques. So in the breast cancer, and especially the so much of advances in the management and the reconstruction procedures and all. So to keep abreast with the knowledge which is has come through, and I am sure that you'll all be benefited with this, and to exchange of knowledge from the experts. And we are glad that so this Red Cross Cancer Institute has come up in Nellore. So under the able leadership of Nageshwara Garu, so he's doing a wonderful job in getting newer advance in the management, and the new machines have come up. They have come up with the to the outreach of all they're not so affordable population of this Nellore and nearby districts. So it's good that to exchange these recent trends in the management. So it'll be we'll have this opportunity, and I wish all the Department of General Surgery all the best for this. And thank you very much.
Thank you for the warm gesture, sir. It's now time to welcome Dr. Nageshwara Garu, Medical Superintendent of Red Cross Society, Nellore, to address the audience.
Good morning, everybody. Thank you, Dr. Mahidar, for inviting me for this CME program. I have a long association with Dr. Mahidar. Actually, we together worked in the same hospital 10 years back in Hyderabad, Lazarus Hospital. From that, I am in touch with Mahidar. He also In 2013, I came to Nellore because of non-availability of the surgical oncologist at that time. Red Cross people were invited me to Nellore. From then, we are doing a lot of service to the poor patients of this Nellore and surrounding districts with the facilities available in the Red Cross Cancer Hospital. And we are associated with the Narayana Medical College. A lot of students coming over there and learning the surgical techniques and seeing what type of patients are getting treated over in our hospital. So I am looking forward to continue this association with the Narayana Medical College. Thank you. Thank you.
Thank you so much, sir. Up next, I'd like to welcome Dr. Sampath Kumar, sir, our beloved professor in the Department of General Surgery, to enlighten the audience.
Good morning. Maybe it's coincidental. I hope you are all aware that Breast Awareness Month is October. And the so-called Breast Awareness Day, of course, a few days back over, was 13th October. And it is very good that we managed to organize this seminar for the benefit of students. Breast, you know, is a symbol of beauty, fertility, and femininity. Unfortunately, the breast is also affected by various diseases, including malignancy. From the time immemorial or from the ancient era onwards, treatment has been attempted because, unlike other malignancies, it's quite obvious because the superficial organ and swelling is obviously felt by the patient herself, and obviously initially because there was no knowledge of anatomy and no other modes of treatment available, they used to remove the breast. It was considered as an amputation of the breast. Subsequently, of course, when we started knowing the anatomy, and William Halsted was the first person who felt that this disease spreads in a stepwise manner from the local area, from the breast to the axilla, then only it can enter into the system circulation. Hence, he started doing, obviously, you all know, the so-called Halsted radical mastectomy. On the top of it, there are some more people who felt that we are not doing anything for the internal memory and supracollateral lymph node. Then they started doing so-called extended radical mastectomy and a super radical mastectomy. But in the beginning of this last century, radiation therapy has come into vogue. Courtesy Madame Curie and Marie Curie, they introduced, rather invented polonium and radium. And subsequently, they felt that this radioactivity will kill the cells. So they had another treatment modality for the treatment of the malignancy. Then, and obviously when this radical mastectomy is being conducted, in fact, this was prevalent for almost 100 years. Then the people started thinking we should modify, because it used to cause a lot of cosmetic disfigurement, physical disability, persistent pain, quality of life was deteriorating gradually. Then there are few people, Patty and Madden, they felt that we can always modify it. And then because the radiation therapy is available, we should be able to give good amount of results, but with less surgery. So then modified radical mastectomy came into vogue. Then obviously, because in the late 1930s, George Bateson, who's a Scottish surgeon, who felt that it may have some relationship with the hormones. Mind you, even in ancient area, in Galen also, he felt that carcinoma of breast is quite common menopausal women. And if the tumor occurs during young age, it was very aggressive. So it was not unknown, but Dr. Bateson, he felt that it is better to remove the ovaries. Then there were good results for a short time. Then one of the Nobel laureates, Charles Hawkins, he felt that adrenal gland is also responsible for the secretion of estrogen. Then he was started rather knocking of the adrenal gland also. Then subsequently, after Second World War, Goodman and Gilman, these are the two people who felt that there are certain medications which are available, like a nitrogen master. And subsequently, there are other chemotherapeutic agents have come into work. And in late 1990s, they identified targeted therapy because of the availability. We are able to understand better the molecular biology of carcinoma breast. Then we started targeting the breast malignancy, and the HER2 has come into work. Then monoclonal antibodies have come. So now survival rate is good, quality of life is good, and I'm sure Dr. T. Nageshwara will tell about recent advances in the management, surgical management of carcinoma breast. Similarly, the onco physician and the radiation oncologist will definitely give their opinion regarding recent advances for the benefit of students. Obviously, when there is a cosmetic disfigurement occurs, we had to do some corrective measures. In fact, it was in late 1819 itself, there was a French surgeon called Melanie. He felt that we are removing one breast, opposite breast is still there. Why not transplant some amount of breast tissue from the opposite breast to this autologous breast transplant? He tried. Of course, it was not very popular. Then, of course, the so-called, we know the tram, pedicle flap has come, was invented almost 30 years back, is still in vogue. Now, of course, there are better modes of reconstructive. I'm sure the plastic surgeon will tell us more about recent advances in the management of post-mastectomy reconstruction of chest wall. With this, I think I should stop, and I'm sure it will be of immense help and benefit for budding surgeons. Thank you.
Thank you, sir. Informative as always. It's now time to welcome Dr. Veerasilingam, sir, our senior most professor in the Department of General Surgery, to address the audience.
Very good morning, everybody. And I'm very happy to be here with you. And for your information, the Department of Surgery is taking a very good academic activities concerned with the postgraduates. Every day we are taking between 2:30 to 4. Every day we are taking postgraduate academic activities. Under the Dr. Mahidar is there, and our professors is there, Dr. G. Prasad and Dr. Other professors is there. And what I would like to tell you, the students, I want to advise 2-3 points. This is an academic activity how come wherever, whenever academic activities going on concerned with the surgery, don't try to avoid, attend. It may be state, national or international, because it will improve your academic knowledge. Concerned with this, what I would like to tell you, don't satisfy with the academic knowledge which you got. Don't satisfy with the academic knowledge which you got. And if you are satisfied, your brain neurons will get atrophied, what I feel. You must always give exercise for your brain cells. That's very, very important. As a senior teacher, as a senior student, what I felt, what I feel to inform you. The next thing is students should have a study motto in the sense, hard work is the secret of success. Without hard work, nothing is there. In the sense, don't believe your luck. I don't believe my luck. I believe my hard work. Therefore, it is just like steps. If I go to steps, I can go for 10th floor. But if you go into the lift, I may not go. Therefore, always your future depends upon your hard work, and that's the secret of success. What I know, and our chairman, Dr. Narayan Garu, was also always telling this when I was in the administration. He was telling the secret of success is hard work. Therefore, I want one to attend any activity, academic activity. Don't avoid as far as go state, national, and international. Number two, do the hard work, and your future is in your hand. Don't stop your academic activity. MS is a very small degree, but for your level, because you're upper for MS is very difficult. But you have to go for super special. There's so many branches of super specialty. This you have to go so that you can serve the people in different ways. Okay, I'm very happy to give a little suggestion to my students, and I'm very happy to be among all of you. Thank you so much.
Thank you so much, sir. Up next, I'd like to welcome Dr. G.V. Prakash, sir, Professor of Department of General Surgery, to speak a few words for the delegates.
Om Namo Venkateshaya. Om Namo Narayanaya. Respected Dean Sir, Medical Superintendent Sir, and other dignitaries of the dais and dignitaries of the dais, and my fellow learned colleague surgeons and learning fellow colleague surgeons. I wish a warm morning. All the best for this workshop. I especially congratulate. Thanks to our HOD sir at Mahidar Reddy, who's taken all the pains and initiative to initiate this workshop, and CME. Our Professor Sampath sir already has given entire encyclopedia of the start and end of the evaluation to involution of entire process of the breast. And our Dean sir has noted a small thing, which is the basic important thing of prevention, being a background of PSM. So I will expect from the today guest speaker, Professor Nagesha Garu, about a part, the prevention part about or the advances, how to prevent regarding gene therapy or prophylactic modulations is available in recent advances in the management of prevention aspect of the CA breast. So with these words, I once again thank Dr. Mahidar Reddy for giving me this opportunity to be here, and I wish you all the best and a grand success of this CME. Thank you.
Thank you so much, sir. Let us now welcome our Head of Department, Dr. Mahindra Reddy Sir Garu, to address the audience.
So good morning, everyone. I welcome all to this CME and workshop. So first of all, I thank all the dignitaries on the stage and off the stage for gracing this occasion, and the Red Cross, particularly the team from Red Cross, because in a very short intimation, they were ready to come. So all three of them. See, I need not speak about the magnitude of the disease. The latest census, what they say is every 22 women, one is affected with breast cancer in their lifetime. So this is not the census in the world. This is the census in our country. So breast cancer has emerged as the leading breast cancer in females. So to commemorating, to provide another point with breast cancer is it's a curable disease provided it is detected at a very early stage. So this every postgraduate should understand. Breast cancer is a curable disease. Like I said, provided at early stage it is detected. So to see that it is detected at early stage, the initiative was initially taken by CDC, the USA, to one entire month, the October month for breast cancer awareness, they have dedicated. So it was soon adopted by the WHO, and even in the Indian government is every year, the entire October month, they are observing as breast cancer awareness month, because see, they want to promote this awareness to see that all the women who are unfortunately about to get breast cancer, they are detected at an early stage. So the commemorating this breast cancer awareness month, the Department of General Surgery has come up with this program, like with the help of the management, and we are planning some 2 or 3 programs again in the line to promote breast cancer awareness. So another 2 programs are in the pipeline, which will soon will be announced. With the help of the management, we are discussing these things, and I request all the postgraduates, the at the end of this workshop, you need to take a pledge that you promote breast cancer awareness in the society. So you come across, you have your relatives, friends, so there are people living in and around your house, your watchman, your maid, you come across a lot of people in your life. Try to see you promote this breast cancer awareness with the simple self breast examination, which we were already discussing. The self breast examination, promote them and encourage them to come for screening. And one major obstacle which has come across in this management of breast cancer is the pandemic. Because of COVID pandemic, the number of people coming for screening mammogram or number of people attending the surgeons have come down. So because of this lapse of time, now most of the women are presenting in an advanced disease. So this pandemic has really stopped the program of breast cancer awareness, which I think with the help of the doctors, you need to promote this awareness and see that we will come back to the normalcy in breast cancer prevention and awareness. So with these few words, I wish this program a grand success. And one thing I just wanted to tell Dean sir and Superintendent sir, for the afternoon workshop, which is on true cut biopsy, the simulations were actually prepared by our PGs, sir. So under the leadership of Dr. Harish and all the first year PGs, they planned a 3D model, and they prepared the whatever the which you will be showcasing in the afternoon, which simulates a breast, the so that the PG will get an idea that he has taken, in fact, a true cut biopsy from the breast specimen. So because future is of simulations, you don't get access to a patient to practice biopsy or not even leave aside biopsy. In future, you need to put a cannula also, you need to take patient's permission, take consent, and some patients won't agree also. So the practice on simulations. So I thank Dr. Harish and PGs for coming up with this idea of preparing a simulating a breast model for a true cut biopsy. So I wish the program a grand success. And so it's, shall we start the program? Okay. So we'll disperse from the stage now, and we'll start the program in another 5 minutes. Thank you.
Honor.
So taking our event further and to begin with our today's program, I find immense pleasure in introducing our honorable guest speaker, Dr. Nageshwar Rao Garu, Senior Consultant Surgical Oncologist, IRCS Cancer Hospital, Nellore. Dr. Nageshwar Rao, working as Senior Consultant Oncologist in Red Cross Cancer Hospital, Nellore. He was a 9th rank holder in MCET 1996. He did his MBBS from Usmania Medical College, did his MS General Surgery, MCS Surgical Oncology, and got NTR University Medal for excellence in PG and super specialty careers. He did more than 6,000 surgeries in IRCS Cancer Hospital, including laparoscopic surgeries. He is a medical superintendent of Red Cross Cancer Hospital, Nellore. I'd like to welcome Dr. Nageshwar Rao sir for his talk.
Good morning, my dear students and senior colleagues. Thank you for inviting me to this CME program. Yeah. Yeah, this is the, most of you know about this Indian Red Cross Cancer Hospital. Most of you might have visited this hospital, serving a lot of poor patients in Nellore and surrounding districts. We have all the facilities for the surgical oncology, medical oncology, and radiation oncology departments. And coming to the today's topic, recent advances in the management of the breast cancer. So, management of the breast, actually surgeon's role will be the control of the local regional disease. It includes breast and the management of the axilla. If you see the management of the breast, as senior professors quoted, the surgery of the breast started with first radical mastectomy done by the Sir William Halsted in 1889. At that time, they used to remove the entire breast, pectoralis major, minor, serratus anterior muscle, and all the level of lymph nodes up to the level 3. It is associated with a lot of morbidity. So surgeons started thinking about how to reduce this morbidity. So a lot of modifications has been proposed. We know there are 3 modifications for the sake of the students. We know that first modification is the Pattis modification, where we preserve where we remove the pectoralis minor muscle to clear the level 3 lymph nodes. Second one is the Scanlon's modification, where you retract the pectoralis minor muscle to clear the level 3 lymph nodes. And the last modification is Auchincloss modification, where you remove up to level 2 lymph nodes and you remove level 3 lymph nodes as on indicated. This modified radical mastectomy also associated with lot of morbidity. By this time, lot of developments has occurred in the field of radiation oncology and the medical oncology. So by this time, people used to think that cancer will spread in an orderly manner, first from the breast to the axillary lymph nodes, then it will systemically spread. This notion has been changed with lot of research and data came from the NSAVP trials. These trials have shown that breast cancer is a systemic disease. As early as 1 centimeter of the tumor, people can have the circulating tumor cells, and these people can have tumor cells already deposited in distant organs of the body. So local radicality of this surgery will not change much in the survival or the local recurrence. So people started doing more conservative surgeries. So they developed the breast conservative surgeries. Still, the morbidity associated with the axillary lymph node dissection was still persistent. So decrease the morbidity associated with the axillary lymph node dissection, people started using different techniques and they find out the sentinel lymph node biopsy, which significantly reduced the morbidity associated with the axillary dissection. And lot of development happened in the field of plastic surgery. So the cosmetic results associated with the breast conservative surgery was very poor. in long term. So people started doing oncoplastic breast surgeries to improve the cosmetic results. So with the experience gained from the laparoscopic and robotic surgeries, now people are doing minimally invasive breast surgeries. This is the famous quote from the Bernard Fisher, he is the chairman of NSABP trials. The quotes, as the quote suggests, says breast cancer is a heterogeneous systemic disorder involving a complexity of host and tumor interrelationships. Variation in local regional therapy are unlikely to affect the survival substantially. So now we are doing more number of breast conservative surgeries because of morbidity associated with the radical mastectomies, cosmetic considerations, and mastectomy is a socially devastating surgery for the women, not only in India, in all over the world. So for all the people, for all the patients, we cannot go for the breast conservative surgery. So what are the indications for the breast conservative surgery? So it is basically done for the early breast cancers, that is stage 1 and stage 2 diseases. We can do in even stage 3 breast cancer, that is locally advanced breast cancers, after downstaging the tumor with the neoadjuvant chemotherapy. So what are the contraindications? If you see the contraindications, in multicentric and multifocal disease, that is not only the primary, the surrounding breast tissue will also have the DCIS changes. Sometimes even invasive tumors can also be present. Synchronous tumors can also be present, where we cannot achieve the complete clearance. So we cannot go for the breast conservative surgery in these people. Second is the contraindication is diffuse indeterminate microcalcifications. In mammogram, the microcalcification usually indicate the presence of the DCIS or the invasive component. So if you see a diffuse microcalcification surrounding the tumor, we cannot achieve complete clearance in these cases also, so that we cannot go for the breast conservative surgery in these patients. Pregnancy is also a relative contraindication because we cannot use the radiation therapy after breast conservative surgery in these patients. Those who have already undergone the radiation therapy is also a relative contraindication because we cannot subject same patient for the redo RT. And large tumor breast tissue also is a relative contraindication. With availability of oncoplastic breast surgeries, we can go for larger excision of the tumors with preservation of the breast. We cannot go in this collagen vascular diseases because a lot of morbidity associated with the radiation. Even in the genetically predisposed conditions like BRCA1, BRCA2, and Lee-Fromney syndrome, these patients have high risk for the contralateral breast cancer also. So these patients also, we cannot go for the breast conservative surgery. Actually, according to the guidelines, we have to do a bilateral mastectomy and reconstruction prophylactically in these patients, as there is high chance of malignancy runs in these families. So basically, breast conservative surgery includes a form of wide local excision. It can be a lumpectomy, or you can remove a complete quadrant of the breast as a quadrantectomy. And management of the axilla in the form of axillary dissection or the sentinel lymph node biopsy. And the radiation also is an important component of the breast conservative surgery. Without radiation, there is increased chances of loco-regional recurrence with the breast conservative surgery. So the importance while doing the breast conservative surgery, so it is basically we are doing a more cosmetic surgery. So for better cosmetic results, we have to plan the incision so that after the surgery, the cosmetic results will be good. So basically, we can go for a transaxillary incision or a periareolar incision or the intramammary incisions. If tumor we cannot remove with these incisions, we can go for the circumareolar Langer lines or the resting lines, or we can use the radial incisions, especially in the if the tumor is involves the lower quadrant of the breast. So basically technique, as I have told, we have to choose the incision according to the location of the breast, and we have to go and remove the entire tumor with 1 centimeter of the margin, normal tissue of breast all around the tumor. After removal of the tumor, we have to place the clips so that better radiation can be planned after these breast conservative surgeries. And we leave the cavity like that only. We usually don't put the drains. We allow the seroma to form after the lumpectomy so that normal breast shape can be maintained in these cases. And we can do the closure as cosmetically as possible with the subcuticular sutures. After that, we have to manage the axilla with axillary lymph node dissection or the sentinel lymph node biopsy. So most important aspect is margins. So how far the breast conservative surgery is safe? So after removal of the lump, we have to mark the margins, superior, inferior, medial, and lateral margin with the threads. We have to ink the surfaces for the better pathological evaluation of the tumors. So if the margins, if there is no tumor on the inked surface on pathology report, then only we can consider it as a adequate breast conservative surgery. If the one of the margins are positive, we can go and redo the excision of that margin, or we can entirely redo the wide local excision of all the margins till we get the negative margin results. If there is still persistent positive margins, we have to subject the patient for the mastectomy. So how far these breast conservative surgeries are safe? So basically safety is measured in terms of the loco-regional recurrence and the overall survival and the disease-free survival. So local recurrence is defined as a recurrent tumor at or near the primary site of index quadrant of the therapy. So if you see the local recurrence rates with the breast conservative surgery and the mastectomy, both of them are comparable. In breast conservative surgery, it is around 3 to 20%, and in MRM group, it is 4 to 14%. How come we come to these conclusions? Because of lot of randomized control trials has been done. Some of them are still continuing. So these are the important trials which has compared the breast conservative surgery with the mastectomy, but they have used different adjuvant treatments. So if you see the local recurrence rates in all the trials, they are comparable. It is around 4 to 14%. The next most important criteria is whether after subjecting these patients, the survival is equal between the two groups. There are 6 randomized control trials has shown no significant difference between the overall survival or the disease-free survival. And 2 trials are still going on, Milan and the NSAB trials, which more than 20 years of follow-up showing the survival equivalence.
So these are the trials. You can see the overall survival is around 65 to 75%. Even the disease-free survival is 65 to 75% between the two groups of patients. As I have told, radiation is the important component of the breast conservative surgery. People have randomized the patient without radiation and with radiation after the breast conservative surgery. You can see in these data, the local recurrence rate without radiation is around 18 to 24%. In some of the trials, it is almost 40%. With the addition of the radiotherapy, it has significantly reduced to 2 to 10%. So if you see the overall survival with the better local regional control with the radiation, overall survival also significantly increased in these patients. So breast conservative surgery, radiation is an important component. After the randomized control trials, usually we go for the meta-analysis. The most important meta-analysis trial in this is early breast cancer trial is collaborative group trial. So it is basically done the meta-analysis of the 9 randomized control trials with 3,100 patients. So after 10 years, there is no difference in the local recurrence rate, which are almost same, and the overall survival, showing that breast conservative surgery can be done safely with no difference in the local regional recurrence or the overall survival. This is the data came from the Tata Memorial Hospital. It also shows the similar local recurrence rates and disease-free and overall survival rates. So after the breast conservative surgery, if you see the initial photo, because of seroma formation, the cosmetic results are okay. But in the long term, what happens? The seroma will be absorbed, fibrous tissue will be formed at the site of the lumpectomy with the poor cosmetic outcome after these surgeries. So improve the cosmetic outcomes, lot of breast reconstructions has been proposed. So which include the breast implants, fat grafting, or the flap procedures, or the oncoplastic breast procedures. I will just go through the just principles of these reconstructions. As our next speaker is a plastic surgeon, she will elaborate more about these procedures. So basically, we can use the breast implants after mastectomy. We can even use it after breast conservative surgery also. After harvesting the fat from the liposuction of different sites of the body, we can inject into the lumpectomy cavity so as to maintain the contour, but it is a crude procedure. So with the development of lot of plastic surgeries, lot of flaps has been available. So we frequently use the LD flap and the tram flap. We can also use the DIEP flap, that is deep inferior epigastric flap, or the inframammary adipose flaps. So oncoplastic breast surgery is a recently evolving branch. So basically oncoplastic breast surgery, we integrate the principles of the plastic surgery like transposition flaps and the rotation flaps with the available breast tissue and fill the cavity remained after the breast conservative surgery. So if you see, this started developing in 1980, and recently only in 2008 and 2010, Alexander Munhoz and Krishna B. Clark, they classified the oncoplastic breast surgeries. So basically, while planning the oncoplastic breast surgery, we have to take care of the incisions, and we have to simultaneously plan the wide local excision, keeping in mind the reconstructive options available depending upon the location of the tumor. So basically, indications for the oncoplastic breast surgery are similar to the indications of the breast conservative surgery. and contraindications also similar to the breast conservative surgery. But we can do reconstruction even after the mastectomy. So if you see the benefits, basically better cosmetic results will be achieved. And the only disadvantage is it will take a lot of time to do the surgery. And sometimes we have to address the contralateral breast also, so that similar results will be achieved in both breasts. So basically this oncoplastic breast surgery, they have categorized into volume replacement oncoplastic breast surgery, where we take the tissue, autologous tissue from the distant parts of the body and fill the cavity like mini latissimus dorsi flap or thoracoabdominal flap. And this lateral intercostal artery flap is used a lot of cases, especially in the outer quadrants and the lower quadrant of the breast, and the thoracodorsal artery perforator flaps. So next category is volume displacement. Basically in this volume displacement, we use whatever the remaining breast tissue present after the lumpectomy, and we redistribute the breast tissue to achieve a better cosmetic results. So basically depending upon the how much tissue you are removing, it is categorized into a simple, that is a level 1, where there is less than 20% of the volume loss, or it can be a complex one where there is a more than 20 to 50% of the volume loss. So if you see for the level 1, as I was told, depending upon the volume of resection, not only the volume of resection, the skin excision also not required in the level 1 reconstruction, whereas it is required in the level 2 reconstruction. And we usually use the mammoplastic techniques in the level 2 resections, whereas it is not required in the level 1 resection. And we have also planned these resection depending upon the glandular characteristics. Basically, after mammogram, we categorize the glandular characteristic on the BIRATS categories. So if it is a fatty, it is a type 1. Second is the fibrogranular type. Third is the heterogeneously dense type. Fourth is the extremely dense type. So level 1 reconstruction will be better those patients who have the dense breast, whereas level 2 reconstruction can be done in the dense or the fatty breast with associated complications. In the level 1 reconstruction, basically we give a skin incision and we undermine the breast tissue all around, including over the pectoralis fascia. And basically it is done from the central tumors. We have to remove the tumor with adequate margins, and we reapproximate the remaining breast tissue to obliterate the cavity after placing the clips so as to assist in the adjuvant radiation, and we close the skin. So basically after doing this, usually nipple will be deviated to the opposite side. So we can give a presenting incision and we can de-epithelialize the surrounding skin and resuture to centralize the breast. If you see the level 2 oncoplasty, basically depending upon the location of the tumors, there are different techniques which will be later discussed by our plastic surgery colleagues. So basically, if it is in upper pole of the tumor, we have to go for the either mammoplasty technique based upon the inferior pedicle, or we can go for the omega mammoplasty or bat swing mammoplasty. If the tumor is located or medial and lateral quadrant, we can go for the radial mammoplasty in the form of lateral or the medial mammoplasty, or we can do in the vertical mammoplasty. If the tumor is located in the inferior quadrants, we have to do the inferior mammoplasty based on the superior pedicle. So this is one of the patient who underwent breast conservative surgery with the reconstruction ever. So coming to the nipple areolar reconstruction, usually we can take a free graft from the opposite nipple, or we can do the tattooing, or we can do the alloplastic reconstruction. So if you see the review of outcomes of the oncoplastic breast surgery, almost 11 studies has been done from the volume displacement and 7 for the volume replacement. All of them are showing the equal local recurrence compared to the breast conservative surgery with a better cosmetic results. So after the management of the breast, now we have to address the management of the back axilla. Basically, axillary dissection is a standard procedure. It is an integral component of the modified radical mastectomy or the radical mastectomy. So axillary dissection basically done for the better loco-regional control, for the accurate staging of the disease. It also helps whether we have to go for the adjuvant therapy or not. And it also helps in prognostication of the patients. So coming to the indications, axillary dissection is indicated basically in all the patients. If you don't have the facility available for the sentinel lymph node biopsy, even in the node negative axilla, almost 40% of the cases pathologically positive lymph nodes will be there. So even in the node negative axilla also we have to do the axillary dissection. So if you see the standard axillary dissection, basically we remove the level 1 and level 2 lymph nodes. Level 3 lymph nodes are removed if they are enlarged or if there is any bulky level 1 or level 2 lymph nodes. So if you remove more than 10 axillary lymph nodes, then only it is considered as a adequate axillary lymph node dissection. So coming to the morbidity of this axillary lymph node dissection, you can see almost 50 to 70% of the patient will have some form of complications. The early complications are erythema, prolonged drainage of seroma, or the wound infection. And the delayed complication and most dreaded complication is the lymphedema. So long-term survivors of these lymphedema patients can also develop angiosarcoma of the limb. So which is seen almost 13% of the patients after the axillary lymph node dissection. And shoulder dysfunction also seen almost in 17%, and pain is seen in 25%, and the arm numbness and chest wall numbness seen in almost 31% of the patients. To reduce the morbidity associated with the axillary lymph node dissection, this sentinel lymph node biopsy technique has been evolved. Basically, by definition, sentinel lymph node is a first draining lymph node on the direct pathway from the primary tumor site. So it is the first node to harbor the cancer cells detached from the primary tumor. So basically, it is based upon the principle that cancer will spread in an orderly manner first from the breast, next to the level 1 lymph nodes. After that, it will go to the level 2 or the level 3 lymph nodes. So basically, people started doing these procedures, experimenting these procedures since 1955. The famous Cabanas node in the penile cancer was detected in 1977, and Morton in 1992 demonstrated intraoperative mapping of the sentinel lymph nodes in melanoma patients. So what are the benefits? As I have told, it will decrease the lymphedema chances, it will decrease the arm numbness, and it will decrease the pain. These are the trials. They have basically randomized the patients into both sentinel lymph node group and the axillary lymph node biopsy group. These trials, Almanac trial or the SNAC trial or DBCCG trials, has shown that there is very less morbidity associated with the sentinel lymph node biopsy. So coming to the indication, we cannot go for the sentinel lymph node biopsy in all the cases. Basically, in the Milan trial or NACB32 trial, they randomized the patient into the sentinel lymph node group if they are positive, they will go for the completion axillary lymph node dissection, and some of the patients directly subjected to the axillary lymph node dissections. These trials have shown that overall survival and the loco-regional control rates were equal in patients of the early breast cancers with node-negative axilla. So basically, we do the sentinel lymph node biopsy in node-negative axillary cases. Coming to the contraindications for the sentinel lymph node biopsy, any procedure which alters the lymphatic pathway, for example, patient if already undergone a breast surgery or patient already undergone an axillary surgery, these patients we cannot go for the sentinel lymph node biopsy. Similarly, in inflammatory breast cancers and locally advanced breast cancers, already with the axillary lymph node metastasis, these patients also we cannot go for the sentinel lymph node biopsy. And relative contraindication, as I have told, even those who have already used the radiation therapy, in those cases also we cannot go for the sentinel lymph node biopsy. So coming to the technique, usually we use the lymphazurin blue dye or isosulfan blue dye alone, or the radiocolloidal alone, or combination of these two techniques. But the recent American College of Oncology Surgeons Group Z10 trial has shown that initially people thought that combination technique is give more results than the individual techniques. But this trial has shown that even large volume of centers, even single technique is also give a similar results to the combination technique. So basically, after giving the dye, usually 4 to 5 ml is given at the time of the surgery, peritumoral or the subareolar, or we can give the radioactive colloid 2.5 millicurie 1 day before the surgery and 0.5 millicurie at the time of the surgery. After giving these, we have to locate the lymph nodes based upon the gamma probe results, or we can do the level 1 axillary dissection, and we have to remove all the lymph nodes which are stained or which have the radioactivity in the lymph nodes, and we have to remove all the palpable intraoperative lymph nodes, because some lymph nodes may harbor lot of tumor cells. These lymph nodes cannot take up the dye, so that all the palpable lymph nodes should be removed at the time of the dissection. So basically, if you remove more number of lymph nodes, the false negativity rate of this technique will be reduced. You can see if there are more than 4 number of lymph nodes, the false negativity rate has come to 0%, and even accuracy results are increased. So that we have to remove at least 4 lymph nodes. So after removing the lymph nodes, we have to subject for the frozen section analysis of these lymph nodes based upon the tumor load. If the tumor load is less than 0.2, it is called as a isolated tumor cells. If it is more than 0.2 and less than 2 mm, it is called as a micrometastasis. If it is more than 2 mm, it is called as a macrometastasis. Based upon the results, we have to decide whether we have to go for a completion axillary dissection, or we can just stop after doing the sentinel lymph node dissection. Usually, completion axillary lymph node dissection is indicated where is technically you cannot locate the sentinel lymph nodes, or all the sentinel lymph node positive patients, or this is one of the criteria came from the American College of Surgical Oncology Group, Z001 trial, where early breast cancer patients with 1 or 2 positive axillary lymph nodes, those who are not undergoing radiation, these patients, as I have told, RT is integral component of the breast conservative surgery. If they are not going for the RT, we have to subject them for the complete axillary dissection. There is a limited data for more than positive lymph nodes, but as of now, we have to go with the complete axillary lymph node dissection in these patients also. So axillary lymph node dissection, usually after sentinel lymph node biopsy, we can stop at the level of sentinel lymph node biopsy. If the sentinel lymph node biopsy is negative, even if the sentinel lymph node biopsy cases, if there are micrometastasis in the sentinel lymph nodes, these patients also, we need not go for the complete axillary dissection. With the data available from the IB CSG trial, it is shown that the micrometastasis cases will have the same results as a node negative patients. So we may not subject these patients to the axillary lymph node dissections. And those with the 1 to 2 axillary lymph node dissection who are undergoing the radiation is also, we may not go for the axillary lymph node dissection. So coming to the role of the sentinel lymph node biopsy after neoadjuvant chemotherapy. So as of now, the standard of care is sentinel lymph node biopsy can be done only in early breast cancer with a node negative axilla. But with the availability of neoadjuvant chemotherapy, even if nodes are clinically palpable before initiating the chemotherapy, what we can do is we can go and mark those nodes intraoperatively. And after giving the chemotherapy, we have to remove whatever the lymph nodes which are marked by doing the axillary dissection, which is known as a targeted axillary dissection. But this is still in research process. As of now, if all the patients with the node positive before the neoadjuvant chemotherapy, we have to go with the completion axillary lymph node dissection. So recently, there is increased use of PET scan. So a lot of patients and physicians are advocating the PET scan for the staging purpose. So what is the role of sentinel lymph node biopsy in these cases? So with the PET scan, we can get a good predictive data for the axillary lymph node status. So those patients who are PET positive axillary lymph nodes, we may not subject them to the sentinel lymph node biopsy. But those who are node negative, even on the PET scan, those patients still we have to go for the sentinel lymph node biopsy because of very poor sensitivity and very poor spatial resolution with the PET instruments. Usually they preclude the detection of the small lymph nodes after the PET. So those patients, PET negative, we have to subject them for the sentinel lymph node biopsy. PET positive, we can avoid the sentinel lymph node biopsy and directly go for the sentinel lymph node biopsy, directly go for the axillary lymph node dissection. So recently, with the experience gained from the laparoscopic and the robotic surgeries, people are doing minimally invasive breast surgeries. Basically, with the same ports, we can do the wide local excision, or we can do the axillary lymph node dissection or the sentinel lymph node biopsy. And some of them are using even the endoscopic techniques for the breast reconstruction, especially laparoscopic mobilization of the omentum to fill the cavity of the lump, or endoscopic mobilization of the tram flap or the LD flap. So using the same principles of the laparoscopic technique, even now people are doing with the robotic techniques also, both breast conservative surgery and the axillary dissections. So what the data shows? So these minimally invasive techniques are just recently used. The nice to view of only one randomized trial or just 8 case series has shown that still we need to evaluate, still we need to do more number of cases, still we need to do more research in the field of these minimally invasive techniques. So as of now, It is not a standard of care. Still, in the experimentally, we can subject the patient with this minimally invasive breast cancers. Thank you.
Anybody, if you have any doubts, you can just clarify this.
Thank you.
Anybody else? Thank you, sir. Thank you so much, sir. I would like to request Dr. Srinivasa Rao, sir, Associate Professor in the Department of General Surgery, and Dr. Chaitanya Kumar, sir, Assistant Professor in the Department of General Surgery, to felicitate Dr. Nageshwar Rao, sir. I'd like to request Dr. Suhas Chaitanya, sir, Associate Professor in the Department of General Surgery, to kindly felicitate our speaker.
Sir, nice stuff, sir. Thank you, sir, for your wonderful talk. So, sir concentrated more on breast conserving surgery. For postgraduates, sir, this 2021 batch, actually, they came in 2022, sir. So, otherwise, they could have completed first year and they could have been in peripheral postings in Red Cross. So, we have decided to send PGs to Red Cross regularly once these people finishes their first year, sir. So, sir is a wonderful surgeon. Like sir was saying, in Lazarus Hospital, we work together. Two good qualities he has got. One is a beautiful dissection. So you can see, he will name all the structures. He does a very beautiful dissection. The other one is he's very cool. The first attitude for a surgeon is, if you keep on doing surgery, if at all there is a complication, surgeon should not panic. He should be very cool. So these two wonderful qualities he has got. And the management has accepted to send PGs to Red Cross. The first years will get the opportunity. So you can be associated with sir. And of course, he has got a full team. The Ushasri ma'am is there and Dr. Tejeshwar is there. So you can learn from Red Cross. No need to go to Hyderabad, Chennai or Bangalore. You have a wonderful center here, right?
Our next speaker is Dr. Tejeshwar, Consultant Medical Oncologist, Department of Medical and Hemato-Oncology, Indian Red Cross Society Cancer Hospital, Nellore. Sorry for the mistake, sir. Our next speaker is Dr. Geeta Ushashri ma'am, MD Radiation Oncology, Head of Department of Radiation Oncology, Indian Red Cross Society Cancer Hospital, Nellore. Ma'am did a post-graduation from MNJ Cancer Hospital, Usmania Medical College, Hyderabad. She was ex-consultant, Belgaum Cancer Hospital, Belgaum, Karnataka. She was worked as next consultant in KCA TRI, Hubli, and Tata Cancer Hospital, Maharashtra. Presently, ma'am is working as a senior consultant oncologist in IRCS for the last 10 years. I now request Dr. Geeta Ushashri ma'am take on the dais.
Good morning, all of you. It's a pleasure and privilege to be here. Thanks for the invite. Thanks, Head of the Department of Surgery, and Medical Superintendent, Narayana Hospital, and our Medical Superintendent, Dr. Nageshwar Garu, for coordinating this event. And then let's jump into radiation oncology. Can someone coordinate there? This is not moving. Oh, okay. So is there any role of radiotherapy in breast cancer? So you've heard the first talk. Previously, it was the surgeons who were ruling the roost. I know all of you are surgeons, but still you have to agree with me. And now oncology is a teamwork of a surgical oncologist, radiation oncologist, medical oncologist, nuclear medicine consultant, radiologist, pathologist, and so many other specialties as well. So radiation oncology is not a backbencher anymore. It comes to the forefront. Once you're done with your surgery, we come to the forefront. So you all need us, both the medical and the radiation oncologist, as your support. So you have to be very courteous with all of us also, hopefully. So let's, the next one. Why is this not moving? Fine, thank you. So locoregional failure remains an important concern after surgery for carcinoma breast. Surgery could be either breast conservation surgery or mastectomy. What are the current indications for post-op adjuvant RT? There are certain nomenclature which all the postgraduates should be knowing. It is post-op adjuvant radiation. The other name is post-mastectomy radiotherapy. Both are one and the same. So what are the indications for post-op adjuvant radiation or post-mastectomy radiotherapy? If you have a locally advanced breast cancer, that is a T3, T4 cancer, you don't upfront operate, you subject the patient to neoadjuvant chemotherapy. Then once there is good response, good surgical, good reduction, cytoreduction following chemotherapy, then the patient is subjected to surgery. That is T3, T4 tumors. Patient underwent radical mastectomy with axillary dissection. So following this, the patient is either given post-op adjuvant chemotherapy and radiation, both together. That is one after the other. So the sequencing is like this. In a locally advanced breast cancer, subject the patient to neoadjuvant chemotherapy first, good response, go for surgery. And after the surgery, complete the chemotherapy, adjuvant chemotherapy, then go for adjuvant radiation. That is the post-mastectomy radiation. This is for the first years. So I'm just being elaborate. So any T3, T4 tumors or any node positive tumors, and the other specific indications are any positive or closed margins, and grade 3, poorly differentiated tumors, and lymphatic invasion and vascular invasion are the most important things you have to look in the post-op HPE report. Once you're done with your surgery, you have to go see the post-op HPE in detail. And the patient underwent any suboptimal axillary dissection, preferably 10 lymph nodes to be removed, and if the patient undergoes any suboptimal axillary lymph node dissection, then you have to subject the patient to post-op adjuvant radiation. This is not an absolute indication, but it combines with the other indication. To summarize, T3, T4 tumors, node positive tumors, grade 3 tumors, lymphovascular invasion, and of course the younger age. Post-op adjuvant radiation is not indicated in patients following mastectomy, following radical mastectomy and axillary dissection in patients where the tumor size is less than 5 centimeters. Suppose I see the post-op HPE report where I have a T1 or T2 tumor on the post-op HPE following a mastectomy and axillary dissection. And I have 0 nodes on the post-op HPE, no lymphatic invasion, no vascular invasion, grade 1, grade 2 tumors. Patient is not young. Margins are very clear. I don't subject them to radiation, post-op radiation. I think this is clear. Why is this not moving? Can someone? Okay. What are the current indications? Can someone come here? Is there any pills or anything to be done? Ah, okay. What is the rationale for post-op adjuvant radiation? That is the post-mastectomy radiation. It reduces the risk of loco-regional failure, and disease-specific survival and overall survival is also increased. So now our surgical oncologist has clearly explained in detail about BCT. So BCT is incomplete without radiation. BCT is nothing but BCS followed by adjuvant chemo if necessary and obviously radiation. So you can't omit the radiation part of this. So following breast conservation surgery, most of the patients undergo radiation. That is even stage 0 patients as well. And early breast cancer, T1 and T2 patients. So as we have discussed, it's a teamwork of the surgical, medical, radiation oncologist, nuclear medicine consultant, pathologist, radiologist, medical physicist, radiation safety officer, and so on. So I just thought before actually proceeding to the proper radiation oncology, I would share with you some 2 interesting old case reports. So I've got this. The next one. This is a middle-aged lady. So she had complaints of headache and seizures. She was rushed to a nearby neurology center, and they have advised her MR brain. So you can, unfortunately, I couldn't get the CT films. This is from 2018, MR films. So this is here, you can see. This is a 2.8 into 2.7 centimeter left high frontoparietal lobe lesion with significant perilesional edema and compression of the ventricles as well. So patient has some compressive effects. So patient immediately underwent, next one. Yeah. The clinical diagnosis, that is the radiological diagnosis, was tuberculoma. So patient underwent excision of the intracranial space occupying lesion. Yes. This patient underwent surgery at SWIMS. I think Dr. Vengamma Garu, she was operated on this patient. And this is the post-op HP of the intracranial space occupying lesion. It is showing poorly differentiated carcinoma deposit. I think you can see it here, the last one. This poorly differentiated carcinoma deposit. So are you happy with this? Would you still want to work upon this? As a part of the oncology team and as a general surgeon, you all need to have a very wider perspective. Breast cancer patients don't come to you with saying I have a breast lump. No. You should have a very, as our surgical oncologist rightly mentioned, it's a systemic disease. You should be very clearly aware of what are the other systemic manifestations as well. So here comes the pathologist role. So the diagnosis was poorly differentiated carcinoma deposit. And here comes the role of IHC. We should all remember immunohistochemistry is very important in this. And before proceeding, you should know what are the tumors which metastasize to brain, especially in a female patient. So CK7, CK20, GATA3, and mammoglobulin were done on this patient. Patient underwent whole body PET CT at swims. So you here there is only 1.5 into 1.1 centimeter lesion. This one in the lower inner quadrant of the left breast, and you should be able to read the SUV values also in the PET CT. That is 6.4. You can actually analyze the metabolic activity of the tumor also based on the SUV values. The next one. The next one. Okay, this patient underwent. The patient came to us, IRCS. This patient underwent bilateral breast mammogram also. It was showing Birad's 5 lesion. So you should always be correlating the radiological picture. This is the mammogram, the PET CT with the pathology report as well. The next one. Yes, this is the IHC, very interesting. CK7, CK20, CK7 and CK20 to be able to differentiate most of the tumors. Both are positive, we have a category. Both are negative, we have a category. One is positive, one is negative, we have a category. And GATA3, this is specific for breast. You can see here, GATA3 is positive here. And TTF, thyroid transcription factor, that is most common in lung and breast. So TTF is negative here. And obviously ER is positive and mammoglobulin is positive. One. Yeah, this is, if you are interested, you can go through this. The next one. Yeah. So now we have a clinical picture of a middle-aged lady who had history of headache, seizures, and went to a neurology department, evaluated with MR brain, upfront operated for intracranial space occupying lesion, subjected to post-op HPE. Here the pathologist, in fact, ours is an oncopathologist, but even a general pathologist should be very well aware of what exactly is a differential diagnosis in coordinating with the surgeon, that is could be a neurosurgeon or anyone of that sort. So this patient, after completing the IHC, and here the pathology report is correlating with the whole body PET CT and the bilateral mammogram. Obviously, patient has only a small lesion in the breast, so she wasn't able to identify it. He underwent total excision of the brain lesion. So we did a post-op MRI. So there was the total response in the post-op MRI. And after that, she received chemotherapy with us. And there's no evidence of residual recurrent mass in the present scan following chemotherapy. As well, even we've done a whole body PET CT following treatment in our hospital, following chemotherapy in our hospital. The next one. And IHC, apart from the markers, ERPR and HER2/neu is mandatory in all breast cancer patients. You have to subject the patient to ER, PR, HER2/neu. Without this, treatment is totally incomplete. 10 years back, we were not doing HER2/neu. Now that the RBC facility is also available for doing a HER2/neu and treatment for HER2/neu, we're doing it now since the last 4-5 years, because ours is an RBC-based hospital. Most of the patients were not able to afford HER2/neu based treatments earlier. And now, even HER2/neu based treatments are coming under our registry. So we are doing it for the last 3-4 years. This is the report of the same patient. Strong positive, ERPR positive and HER2 negative. Next one. This is after subjecting to chemotherapy. We don't say it's neoadjuvant because the intent is palliative in a metastatic setting. So after subjecting to chemotherapy, 8 cycles of chemotherapy, patient also underwent surgery and after the PET CT, patient also underwent surgery in a hospital. You can see here there is absence of residual carcinoma. The impression. The next one. Next one. This is one more case report. Case report 2. This is very, very interesting. This is a middle-aged lady. She had complaints of backache. So she consulted a nearby surgeon or physician. She underwent a CT of the chest, which was showing a multiple lytic lesions. Unfortunately, we couldn't get the CT images. It was in 2019. Multiple lytic lesions in the visualized dorsal vertebra. So obviously, the diagnosis was of a multiple myeloma or a metastasis. The next one. Because the diagnosis was a probability of multiple myeloma, patient underwent bone marrow aspiration as well. This was in Vizag, yes, Visakhapatnam. Bone marrow aspiration, it was an aspiration. Remember that it is only cytology, bone marrow aspiration cytology. So it was consistent with metastatic deposits of poorly differentiated adenocarcinoma. So once you do an aspiration and only a cytology, you don't subject the patient to a biopsy. So it will be difficult to do a IHC markers on this one. The next one. So this patient also underwent true cut biopsy outside, but this is so whenever we see this patient came to us, whenever we see a pathology report, it is always mandatory in a specialty setting that we re-review the pathology report with our pathologist. So the report of this bone marrow aspiration was reviewed in a hospital. It was suggestive of metastatic adenocarcinoma. Now that you have a report of a metastatic adenocarcinoma, that is a middle-aged lady with backache, multiple lytic lesions, and bone marrow aspiration suggestive of metastatic adenocarcinoma. What next? So in this patient, once we are done with the slide review of the bone marrow aspiration, the next one. This patient underwent true cut biopsy, again outside, somewhere in Bangalore. Yes, Narayana Medical College, Bangalore. She's migrated from Vizag to Bangalore again. The true cut biopsy, there's no breast parenchyma seen in this biopsy. Next one. Again, this patient came to us, fortunately. We have done a ultrasound guided true cut biopsy of this patient. Because the earlier true cut biopsy was negative. We have asked for an ultrasound guided true cut biopsy. And this is biopsy, this is not an FNAC. So features are suggestive of invasive duct cell carcinoma. Now, once we have a biopsy report, we are very authentic in this. Next one. This is the whole body PET CT of this patient. We don't have a PET CT curve, so I mean, at that point of time, 2019, the patient underwent PET CT at SWIMS. So here, next one. Yeah, you can see a small lesion in the breast, 1.4 centimeter lesion. Next one. PET CT features are consistent with extensive skeleton. Now, once you see this report, the earlier clinical picture is correlating this radiological picture with the breast triangle. The next one. Yeah. This is, here you can see this. This is a very small breast triangle. As I told you, patients don't come upfront saying that we have a breast lump. This is the PET CT picture, very small breast lesion. Very interesting, right? The next one. This patient underwent IHC on the biopsy. Because it was an biopsy, we could do an IHC. This is where FNAC versus biopsy comes into role. The next one. Done with this two interesting cases. I feel these are interesting for all the postgraduate students, at least the first and second year. Now, going straight forward to the radiation aspects. It could be a little boring for all of you, but you have to know. Yeah. So, as we have discussed, radiation is indispensable. Radiation oncology as such, most of the patients following either a breast conservation surgery or a mastectomy, they have to undergo, at least 70% of the patients, they undergo radiation because of the clinical indications. So following a BCS, following a breast conservation surgery, this is the volume, what I draw on the patient. This is the CT volume. This one. This is the volume and this is the boost volume. Next one. And I do include the supraclavicular and the axillary lymph nodes also, if indicated. The next one. So how do we do the boost? How do we do the treatment to the primary tumor and how do we do the boost? Treatment to the primary tumor is with photons. So photons can be delivered either with cobalt or with linear accelerator. Cobalt is still existing in developing countries. You can't totally dispose of the cobalt machine because linear accelerator as such is about 10 crores. So all the developing countries can't afford that. So once we are done with the photon therapy for the primary tumor site, post-op site, following a breast conservation surgery, we include the whole breast, of course, but the boost is given to the primary tumor site, post-op site. So boost can be given by electrons. This is an electron cone. This electron cone is attached to the linear accelerator. This is electron cone. It is attached to the linear accelerator as such. So it is the lumpectomy cavity plus 2 centimeter margin in all directions. The next one. So why do we need to do an electron boost? Why not photons? So once we are doing a photon therapy for the whole breast, why are we going for an electron boost? Because the 90% prescription isodose line is limited to the chest wall to decrease dose to the lung. This is possible with electrons. Once you give a target to the electrons, it just hits the target. Beyond the target, the dose is very minimal. That is the advantage of electrons. Whereas the photons just pass through and through. Photons is nothing but the X-rays, whereas the kilovoltage X-rays you use for a diagnostic purpose, and megavoltage you use for treatment. That is the only difference. Next one. Electron boost, why is it preferred? Is relative ease in setup, outpatient setting, lower cost, decreased time demands in the physician, excellent results. When compared with the interstitial, there's something called an interstitial boost technique. It is an invasive procedure. Once this electron boost is becoming more popular these days with the more availability of linear accelerator, we're not doing interstitial boost. We were doing it way back, probably 15, 16 years back. Now, frankly speaking, I'm not doing any interstitial therapy since the last 10 years. The next one. This is how we mark. The next one. This is the interstitial brachytherapy, the invasive procedure. So you should be thinking how radiation is delivered through interstitial brachytherapy. Once intraoperatively, it's radiation oncologist who place the catheters with the help of the surgical oncologist. So once this is done intraoperatively, you can see the tubes and wires here, right? So we have something called a iridium-based afterloading HDR brachytherapy, high dose rate brachytherapy machine. So with the help of that machine, there's something called a radioactive source called iridium. The machine is very small. The machine what we use for external therapy is very different from what we use for brachytherapy. That we should remember. For external therapy, we use linear accelerator. For brachytherapy, it's the iridium. It's afterloading. It's not a preloading. It's an afterloading machine, and it's computer controlled. So once we optimize the plan, once we do sit with the radiation safety officer and the medical physicist, then what we do is this. Here we can see the machine has got something called a wires. So the wires are attached to this. The source passes through these wires, goes inside, stays for a certain period of time. The amount of time it stays inside is controlled through the system. Next one. Next one. Yeah. Methods of boost, either photons, electrons, brachytherapy, interstitial or intracavity mammocyte. Next one. This is the posterior axillary boost. Next one. So usually the treatment period you need to know after completion of PCS. What is the treatment duration for radiation? It's around 5 to 6 weeks. Initially irradiated for whole breast, that is around 4.5 to 5 weeks, followed by a boost of a week. So most of the patients, or at least some of the patients, they're not happy with this 5 to 6 weeks of treatment. So we have another technique for that, accelerated partial breast irradiation technique, where the treatment duration is shortened, where we give twice a day treatment for these patients. So we have something called a conventional RT and a conformal RT. If you ask me any branch in modern medicine which has where the technology has really revolutionized the treatment aspect, radiation oncology is one among them. I'll show you pictures of, you need not know the detail, but I'll just show you pictures of what exactly is conventional and conformal RT. So here the patient is placed in the face down position, where the left lung, heart, you can see here. You can see the left lung and the heart. So they have to be avoided at any cost because these are called the OIRs, organs at risk. So we identify the position based on the treatment schedule. The next one. This is a conformal technique where this is a conformal technique. So you can see the beam passing through and through. This is the lung. The basic idea in conformal technique is minimizing dose to the lungs and to the heart. This is the boost to the tumor site. We've already discussed after whole breast starting. So this is a cobalt-based treatment, and this is the linear accelerator-based treatment. Cobalt has low energy, 4 MeV, and high energy with linear accelerator. It has can have dual energy photons or triple energy photons along with electrons. For electron treatment, we don't need to have special equipment, but for the linear accelerator with an electron cone. The next one. Next one. This we have already discussed. This is a chest wall CTV after mastectomy. We were initially seeing the what is the clinical target volume of following a post-op following BCS. Here we are seeing after mastectomy. You can see we try to eradicate only the chest wall. Here this is the opposite. So here we are trying to eradicate the chest wall, minimizing the dose to the lungs and the heart. The next one. So this is more important, at least you need to know the names. 3-dimensional conformal radiotherapy, intensity modulated radiotherapy. These are part of the conformal techniques. So what is conformal? We just confine to the target area. The next one. Okay, this is the evaluation of radiotherapy. You can read the books as well. The next one. Yeah. Here you can see this is the target. Suppose imagine this is the target. What is a 2D plan or a conventional plan? It comes like this. So you can't sculpt it actually, you can't conform actually. So if it's a 3-dimensional conformal, you can do it At least do it in this shape. Conform to the shape of the target. What is IMRT? See how beautiful it is. You can actually shape it, confirm it, modify the intensities. The next one. And this is a cobalt machine. Next. The conventional is nothing but the 2D techniques, 2D conventional radiotherapy. With possible with cobalt, even with cobalt, we can do 3D techniques as well. The next one. This is how, for example, 2D technique looks like. Yeah. Suppose this is the target area. With the 2D techniques, conventional techniques, only this we can irradiate like this, but we can't actually confirm to the tumor site. Next one. Now comes the conformal radiation. 3D CRT and IMRT, multiple beam directions are possible, and you can modify the intensity of the beams, shape the beams. You can use image guidance, immobilization, accurate patient setup, accurate delivery of the dose. All these are very important in conformal radiotherapy. The next one. Next. Just imagine a small room with a good tube light. So what do you see at all the corners of the room? You can feel the same intensity. So that is the nothing but the 3D CRT. Suppose you are able to modify the intensity of the beam. That is where at each corner of the room, you can see a different intensity, different fluence of the beam. That is IMRT. So the top one is 3D CRT, three-dimensional conformal radiotherapy. This is, see here, you can modify the intensity of the beam as well. This is an IMRT technique. Isn't it very beautiful? The next one. Basic idea of conformal is, again, adequate dose to the tumor and minimal dose to the critical organs. Next. Just wanted to show you some pictures. Here in conformal radiation, the beam shaping is with MLCs. These are the MLCs, multi-leaf collimator, which are there in a linear accelerator. How is this possible with MLCs? We'll go to the next one. Next. Next. These are the MLCs, multi-leaf collimator. As such, these are inbuilt in the linear accelerator, and this is the target. Next. Next. The next one. IMRT is an intensity modulated radiotherapy, is an advanced form of conformal therapy. It uses non-uniform fluence beams. Next. This, go back. This is what you need to know. What exactly, how do we actually do conformal radiation? Isn't it a tedious job? Is it so easy? No. So the most important is, suppose you identify a patient has a breast cancer, undergoes breast conservation surgery. Then after that, subject the patient to chemotherapy if the medical oncologist wishes to do so. And after that, patient is coming for radiation. Then how do we go back? How do I do that? Once the patient comes to me, yes, the treatment is indicated. Then I determine the patient's position. So I just say to my technologist, this is the position I want to be. The patient has to be positioned like this during treatment. So this is the first step. So this is not the treatment aspect of it. We have something called a mold room. So can you see something here? The orthoped, where the patient has to be immobilized. Patient shouldn't be able to move during the planning, pre-planning, and during treatment as well. So this is something called an immobilization. Positioning and immobilization is the first step in pre-planning. It is not planning, it is pre-planning procedure. Then once the patient is positioned and immobilization is done, here we use lasers also to position patient accurately and place the orphid or whatever is the immobilization device. Once this is placed in the mouth room, the technicians, RT technicians do that. Once this is placed, then patient is shifted to the CT simulator. So now even at IRCS, we have in-house CT simulator available. So we have, it could be either dedicated CT simulator where the CT simulation is done only for radiation purpose, or you can have a diagnostic CT as well. The basic difference between the diagnostic CT and the CT simulator is you should be able to have a wide bore one with a flat couch. You have a flat couch and a wide bore. You can use it for a planning purpose also. Now here you acquire the volumetric data. It could be either CT, MR, or PET. Whatever is feasible and available here, after positioning and immobilization is done with the cast, shift the patient to the CT simulation room, take planning CT images. So once the planning CT images are taken here, then we have DICOM, digital communicating system. With that, here the volumetric data set is transferred to the treatment planning system. It is nothing but a computer software. So once it is transferred to the treatment planning system, here the radiation oncologist sits, and in each section and each slice of the CT scan, we contour the GTV, gross tumor volume, clinical target volume, planning target volume, giving adequate margins for setup errors, patient movement errors, then also contour the organs at risk, lung, heart, whatsoever required for that patient. Contour in each slice and section of the CT scan. That is in the treatment planning system. Once you are done with the contouring section where we contour, so once we are done with this target volume delineation, once we are done with this, now we will decide if 3D CRT patient is being subjected to or IMRT. So if I find 3D CRT is enough for this patient, conformal 3D conformal radiation, then I ask my RSO or the medical physicist to set up some plans, show me some plans, and I'll review those plans. Plan 1, plan 2, plan 3, plan 4, plan 5, or whatsoever. So once these plans are reviewed, we will analyze the plans along with the RSO and the medical physicist, where the dose distribution to the target area is homogeneous. At the same time, dose to the target non-target areas like the critical structures is very minimal. Once this is done, we do a QS and treatment delivery is done. And how is the treatment delivery done? From the planning system, the images, the planning images, the contouring images, the planning images are transferred to the machine. That is the linear accelerator machine, which has a software, the same software as that of the planning machine. The images are transferred to linear accelerator machine and treatment delivery is done with the help of the radiation technician. This is the process of doing so. But in volumetric data acquisition, if you have a CT, MR, PET, PET is much better because that is a functional scan. You will be able to recognize the target areas much clearly and very aptly. I think all of you understood what is actually about radiation. The next one. So as I told you, positioning is very important. Next. This is a breastbone. So can you see this? How the patient is positioned, pre-planning as well, pre-CT simulation as well. Position on the breastbone, the same breastbone to be used while doing a CT simulation, while doing planning, and while during treatment as well. So you can see the immobilization here. Patient hand is placed here, fixed, and body is placed here. We use lasers as well. These are the other immobilization devices for other areas. The next one. This is a mat block pelvic immobilization, head and neck immobilization, so on. Next. Image acquisition. We have discussed this in detail. It could be either CT based image, MR based, or PET CT based image. Next. Next. This is the CT simulator, same as that of this diagnostic CT machine, and this MR PET CT. Next. Advantage of CT imaging is gives detailed information of bony structures. 4D imaging can also be done. 4D imaging is nothing but the gating. You account for the gating of the patient, that is the respiratory movement of the patient. The next one. Next. A large bore is something of 75 to 85 centimeters with a flat couch. These are the two prerequisites for having a CT simulator. Or you can, by choosing a diagnostic CT scan, if you want both a diagnostic and a planning CT as well, you can choose this, a machine with a large bore and a flat couch with a laser system. Next, I'll be showing only pictures. This is how we do an image fusion and an image registration. Suppose we have both CT, MR images are available for the patient. That is the planning images after the diagnostic images. Diagnostic images are different from the planning images. So once we can fuse both actually for better tumor delineation. Next. This is the contouring session done on the treatment planning system. Next. We have some guidelines. How do we define the target volumes? ICRU reports 50, 62, so on and so forth. So at least you need to know some definitions. GTV, gross tumor volume, clinical target volume, planning target volume. OAR is organs at risk. Next. Next. This clinical target volume is nothing but the gross tumor volume with the subclinical microscopic disease. It usually includes the regional lymph nodes. OARs, those are the organs at risk. Should give some margin for setup errors and patient motion as well. So this something GTV, CTV, PTV. This is the macroscopic tumor. This is the microscopic tumor. This is the planning target volume. We have some, based on these reports and recommendations, we accurately delineate GTV, CTV, and PTV. Next. This is how it looks like. This is the, here comes the GTV. This is the CTV. And this is the planning target volume. Suppose you have a functional scan like that of a PET, so you will have a better tumor delineation. Next. So we have dose constraints for OARs also, organs at risk. So we have to take into account the dose constraints, that is the volumetric dose constraints for OARs before finalizing the actual plan. This is how we see DRR, digitally reconstructed radiograph. That is, once I'm done with the contouring session, and once we are done with the putting the beams, how many beams, which side, where to go, how to go, then we see something like this. Suppose a head and neck patient, we see something like this. This is outer. These are the MLCs, multi-leaf collimators. This is the actual target volume. These are called a digitally reconstructed radiograph. On a daily basis, we see this, and we take DARs every day, twice in a week, or it all depends on the institute's protocol, and match the treatment DRRs with the pre-planning DRs. That is how we maintain accuracy of the treatment. The next one. Next. This is something called a beam's eye view. That is, how does the target volume look actually if you look from the beam's eye? This is called a beam's eye view, this one. This is possible in the latest linear accelerator machine where we can see planning systems. We can see what actually, how does this target actually look if you see from the beam. The next one. This is a room side view, same as BEV, but from the room, how do we actually perceive it? Next one. CDCRT is a forward planning where we discuss with the medical physician and the RSO saying that put this beam, that beam, and so on and so forth. And finally, we optimize one plan. That is a forward planning. Whereas IMRT is nothing but an inverse planning where, go for the next one. Yeah, this is an inverse planning where you already have given the target where you say this volume should get this much amount of the dose only. So I have certain constraints for this. Based on that, we have to design the plans. It is not the other way around. So contouring is almost the same, but it is more constrained, more conformal, and the intensities are modified, more difficult, more time taking, more time consuming, both for the physician as well as the other radiation staff. Next one. Yeah, this is the inverse planning in IMRT, intensity modulated radiotherapy. Next. Go to the next one. We do an optimization as well for the radiation beams. Next. This is we have already discussed. This is conformal therapy. Next. This is DVH, dose volume histograms. On the system, before we actually implement the treatment on the machine, after the contouring session is done, we analyze for each organ. How is the dose for the amount of volume given? This is called dose volume histogram. Very tedious process of doing this. Next one. A plan evaluation. Next. This is a 2D evaluation. A conventional technique. Next. Next. This is again DVH. Next. You see cumulative and differential DVH as well for the OARs and for the targets as well. Next. Finally, after the radiation oncologist, along with the radiation safety officer and the medical physicist, is happy with the radiation plan and all the parameters are satisfied, we implement that on the patient. And that is not the end of the day. Every day is a day for us because we have to see that the same treatment plan is being implemented on each day. At least the treatment duration is for 5 to 6 weeks. So the verifying system is very important for us. So we usually do if not daily, a weekly based what is this a verification system where we take a DRR, compare with the pre-planning DRRs. Next. Go to the next one. Yeah. Go to the next. So IMRT delivery could be a static technique or a dynamic mode. Next. Yeah. Picture. I think this we have seen earlier, but then you can see it again. This is how it is. You can see the multi-leaf collimators here. Yeah, these are the multi-leaf collimators. How beautifully they have just stuck to the target. See, these are already in the linear accelerator itself, computer controlled. So once the plan is finalized, these move accordingly. This is the target. Next. This is again IMRT, different modes of doing an IMRT. Next. Next one. Maintaining quality assurance is very important while doing conformal techniques. Next. Again, tomotherapy, another interesting word. Then again, an IMRT where rotational fan beams are used. Next. This here you can see. This is tomotherapy. Next. Again, this intensity modulated arc therapy is almost similar. The next one. Volumetric modulated arc therapy. It's nothing but a rapid arc. The next one. This is rapid arc. It's nothing but a little sophisticated linear accelerator. Nothing more than that. Little expensive. Next. Yeah, take home message. This is a 3D. You should remember conformal versus conventional techniques. Conventional techniques are no longer preferred. Conformal techniques do well. This is a 3D conformal radiotherapy. This is an IMRT. Still, these are 3D techniques only. IMRT is more conformal. This is forward planning. This is inverse planning. In here, you can modify the intensities. So you have a high gradient dose, even in the target area. Next. The next one. Suppose you have a very critical organ very near to your target site. Preferably, we do an IMRT. As simple as that. That's all. Thank you. Thank you for your patient listening.
Thank you, ma'am, for the informative talk. The floor is open for questions if anybody wants to ask.
So, ma'am, thank you, ma'am, for your wonderful presentation. So, ma'am, may I know what radiotherapy facilities are available in Red Cross Cancer Hospital? So, first of all, thank you, ma'am, for your wonderful talk. So, can you acknowledge what radiotherapy facilities are available in IRCS?
Similar as we have already discussed, it is for conformal techniques. And we're expecting a linear accelerator in another month. But yes, a month or so, we're going to have a linear accelerator. Till that, we were doing conventional techniques. But still, the results are good. But we're expecting much better results with conformal techniques. Because of lack of facilities, we're doing conventional techniques only. But we do have HDR brachytherapy. That is regarding brachytherapy, we do have state-of-the-art iridium, HDR, computer control, afterloading brachytherapy. That we have. But regarding this, regarding the conformal technique, another month will be done with.
So, because quite often patients will be asking us, we don't have an oncology unit, we'll be referring, they will be asking so and so facilities available or not. So that's why I wanted to get this from you.
Yes, so following as of now, following BCS,
yes.
We are not in a position to treat radiation. Just a month or so down the line, we'll be able to take up those cases as well.
Yes.
But following mastectomy, yes, we are taking up.
Yes.
Madam, what is the dose? Same thing, total dose for say breast is 4, 5 or increase now or change total dose?
You're asking about total dose,
Yeah,
sir?
yeah.
Yes, sir. So
How many
following,
rats?
yes, sir. Following mastectomy, treatment duration is for 5 weeks. So we deliver the dose for 5 days in a week for 5 weeks. Treatment duration is approximately for 15 minutes in a day.
Yeah.
So it
How
will
many
be around
rats?
50 gray. The dose is mentioned as gray, 50 gray in 25 fractions, 5 fractions per week. That is following a mastectomy. Following a breast conservation surgery, the treatment duration is again different. Following a BCS, we want to irradiate the whole breast followed by a boost to the primary side. So 45 gray in 25 fractions will be the dose to the whole breast. 45 gray in 25 fractions again for 5 weeks. So we don't give more than 5 days in a week. That is the first rule in radiation oncology. So it is for 5 weeks plus the boost technique. That's for 1 more week. But still not practicing accelerated partial breast irradiation or accelerated treatments here.
Okay.
Usually those are done in big institutes only. In routine practice, we still do 6 weeks treatment for BCS and 5 weeks treatment for mastectomy patients.
Thank you.
Ma'am, one more thing. See, because these PGs, you can freely ask questions. Some are just putting a message to me to ask. Why don't you ask? You can freely ask, ma'am, to any doubts you can. So, ma'am, is that for downstaging breast cancer before surgery? Is it neoadjuvant chemo or neoadjuvant radiotherapy, ma'am? Because of course, the next session, sir will be continuing on that. But before that, which is good, ma'am? Neoadjuvant chemo or radio, or how you decide?
For the PG's question, answer is neoadjuvant chemo is first preferable. Only few cases chemo with RT is advocate, like madam said. So mostly it is chemo is first choice, and the precaution is whenever you have going for neoadjuvant, you should keep the first biopsy report as well the first biopsy specimen as well to safeguard. Once after sometimes a full response, then the tumor might disappear or the pathology might change. HPV report might change, whether receptor positive to negative, negative positive. That will be in soup. Otherwise, to safeguard, you should have the report as well the specimen also.
And one more thing for postgraduates. See, when ma'am was saying about cobalt, she was saying the therapy is mainly by means of photons. And some of you were baffled. Sir, we studied gamma rays. Ma'am is saying photons. See, photon is a packet of energy or light. So light, it is not restricted to the visible spectrum. So even the higher frequencies of electromagnetic spectrum have this gamma rays, the X-rays. So a packet of energy, even gamma rays, a packet of gamma rays energy or frequency, that also is a photon. So photon is not restricted to visible light. Visible light is just a part of electromagnetic spectrum. If you go higher and in the high frequencies in the electromagnetic spectrum, you have gamma rays, X-rays. So they are non-visible, but they are also a packet of energy. So when ma'am says photons, gamma rays also, a packet of energy of gamma rays is a photon. So again, some pages were a little bit confused. So just to clarify that.
I'd like to request Dr. Zarina ma'am and Dr. Venkat Haris sir to felicitate ma'am with a shawl and a moment. Thank you, ma'am. Thank you, sir. We'll be taking a 10-minute tea break for now and we'll gather after that. Thank you. Welcome back to the second session of the CME. Our next speaker is Dr. Tejeshwar, Consultant Medical Oncologist, Department of Medical and Hemato-Oncology, Indian Red Cross Society, Cancer Hospital, Nellore. Sir did his MBBS in Kurnool Medical College from 7 to 12. He did his MD in Internal Medicine from AIIMS New Delhi. He worked as a senior resident in Sir Gangaram Hospital, Delhi and AIIMS New Delhi. Sir did his DM in Medical Oncology from Jipmar, Pondicherry. Now he works as Consultant Medical Oncologist in IRCS Nellore. Sir was awarded second prize in Jipmar BMT CME quiz. Sir was also winner of PG debate in colon cancer. Sir came first in the TV essay quiz 2022 in South and East India zones. Apart from these, Sir has numerous abstracts, publications, and voluntary services under his name. I'd like to request Sir to kindly come out to the dais and speak a few words for our delegates.
Hi, good afternoon, everybody. So my name is Tejeshwar. I am feeling very happy to speak to all of you in this prestigious institute. And I'm also feeling very happy to see Harish sir over here. Sir is my senior. And respected seniors and dear residents. So today I'm going to speak on recent advances in systemic therapy in breast cancer. So I have changed the topic. Previously, it was printed as in recent advances in chemotherapy, but I have changed it slightly. Recent advances in systemic therapy, because we will give a drug. It can be chemotherapy or targeted therapy, or it can be a pill, which can be like tyrosine kinase inhibitor that will act in that will enter into our circulation, and it will act in a systemic way. So that's why I changed this topic to recent advances in systemic therapy in the management of breast cancer. So first, you all have heard about recent advances in surgical oncology and radiation oncology. So now you all have been given a lot of information. But let me see what are recent advances in systemic therapy. So once we think of why there are a lot of recent advances in systemic therapy, see, we are all happy with chemotherapy alone. Why we need a lot of advances? Because we want to give more to our patients. So that's why we need we need a lot of advances in the treatment. The same happened with the field of systemic therapy too. So the recent advances in the field of medical oncology are mainly because of a better understanding of the disease. Now, previously, we used to see the disease at the level of the at the level of the histopathology, that is with the H&E staining and all. So, but now we are having a deep and clear understanding of the disease. Now we are seeing the disease we are seeing the breast cancer at the level of the molecular level. So as we are seeing the disease at the molecular level, we found out newer novel mutations, and these mutations are the now for those mutations now we are giving the targeted therapy. So these are the recent advances in any kind of malignancy. You take it as an blood cancers, or you take it as a breast cancer. The way we are seeing the disease is improving, and now we are seeing the disease more deeply and more clearly, and we are giving therapy at the molecular level, and this lead to another new era of therapy that is called as an precision oncology. So the same thing happened in the breast cancer also. Previously, in 90s and 80s, we are having an basing on the histopathology, we are giving chemotherapy. So chemotherapy in breast cancer, for you as a surgery residents, it is important in two ways. One is as a neoadjuvant chemotherapy and an adjuvant chemotherapy. I'm going to restrict myself to curative setting, that is neoadjuvant chemotherapy and adjuvant chemotherapy. The therapy which is going to be given prior to the definitive treatment, that can be surgery or that can be radiotherapy. So prior to that one is called as a neoadjuvant therapy. And the therapy which we'll give after the definitive treatment, after surgery or radiotherapy, is called as an adjuvant therapy. So it can be chemotherapy, it can be targeted therapy, it can be immunotherapy, whatever we can give prior to definitive treatment or after a definitive treatment. So after the histopathology, then came this is. Can anyone guess what is this one? This is an IHC. IHC of what? So this is an IHC of, this is a nuclear staining here we are seeing. This is an ERPR staining. So ERPR receptors are present in the nucleus. And here we are seeing it is an ERPR staining. And now because of that discovery, newer discovery, we are having an, now 1 minute. So this one is, so this is the membrane staining. Here, this is also IHC. This is the membrane staining of HER2/neu. HER2/neu is expressed on the membrane of the tumor cells. So we are seeing an HER2, this is an HER2 expression, and it is quantified based on the intensity of the expression. And the next one is, this is regarding the PDL1 expression. This is the relatively newer one. This is also seen by IHC, which can be used as a marker for immunotherapy. And the last one is, now we are seeing the disease at the level of the genome. So now we came up newer technologies like next generation sequencing, which lead to the discovery of newer drugs like BRCA1 and BRCA2 inhibitors, like PARP inhibitors. So these molecular biomarker discovery and the therapy discovery always goes in hand. Okay. If you see this, the red one, there are a lot of newer drugs. The red ones are the few highlighted ones, which are the recent discoveries in the last 5 years. So there are a lot of things. You people no need to remember all these things. But the thing is, you have to remember, as the understanding of the disease improves, the way of systemic therapy also improves because of the newer biomarkers. So I'll go with one of the new case, one of our case. She is my patient at Indian Red Cross Hospital. So basing on this case, I will take you through the newer discoveries and how we have treated that patient. So she is a 56-year-old lady. She presented with a lump in the right breast of 3 centimeter size with the right axillary lymphadenopathy, and her through-cut biopsy is suggestive of an invasive ductal cell carcinoma. And if you see an IHC, here the most important thing is her HER2/neu is 3+. Here 3+ is means it is an there is an intense membrane staining, and also there are more number of cells have been expressing the HER2/neu. Then CT, in view of lymphadenopathy, we have done a CT, and CT was showing an 2.5 centimeters lump with axillary lymphadenopathy. So she's a 56-year-old postmenopausal lady with clinical T2N1 breast disease with HER2/neu positive. So how I'm going to treat this patient, and now actually how I'm treating this patient, both ways I will show you. So one thing is, see, HER2/neu is a marker which is present in the tumor cells, and it is a very bad prognostic marker until the discovery of the newer drugs. So if you see this thing, this is the survival probability, overall survival. If you see this green one is the survival of HER2/neu positive patients, and the yellow one is the triple negative breast cancer, means they are not expressing any of these things. So the survival of these patients is very poor when compared to luminal A, luminal B, luminal A cancers, mainly because they are highly expressing hormone positive. So when compared to those patients, these patients are doing very poor even with chemotherapy and surgery and definitive treatment. So then how I am going to improve? So this patient is also HER2/neu positive. If I give only chemotherapy for this patient, I am not going to give much benefit to that patient. So how I am going to improve for her survival? So I want to show this video, but it is not playing, but I will show you another one. So this is about the HER2/neu inhibitors. Then came the HER2/neu inhibitors. Like, for example, if you take a disease among all malignancies, a disease which acts as a prototype for the targeted therapy is chronic myeloid leukemia, where we found imatinib, and it has revolutionized the treatment. The same happened with breast cancer also. Trastuzumab is the first monoclonal antibody, and it has revolutionized the treatment of the breast cancer. See, this is the HER2. HER2 is expressed, and there are different types of HER receptors. HER means human epidermal growth factor receptors. So they are expressed on the surface of the tumor cells. What happens in breast cancer is there is an increased expression of the HER2. So this HER2 acts by the downstream pathway. If it gets activated, the downstream pathway gets activated. That is PIK3 AKT mTOR pathway, and there is going to be an increased proliferation of the cells and increase survival of the cells. So what trastuzumab will do is, trastuzumab is a monoclonal antibody. So this monoclonal antibody is specific for HER2. So it will come and bind to the HER2. So if it binds to the HER2, then what will happen is these downstream pathway will get inhibited, and the mechanism is known as antibody dependent cell mediated cytotoxicity. So then there is going to be a decrease cell apoptosis and cell death. So this is how trastuzumab is going to act. And so after trastuzumab, so if I offer this trastuzumab to her, then I'm going to improve the survival. This is called as a disease-free survival, and this is an overall survival. In any malignancy, we are always we always used to see with disease-free survival or overall survival. Disease-free survival usually comes in an curative setting. It is nothing but if you take from the time of randomization, if any specific therapy is given to that patient. So till the disease progression or death is considered as disease-free survival. And overall survival is pretty much clear from randomization till death. So that is taken as an overall survival. So here disease-free survival as an extra component, that is, it includes first progression also as an event. So here if you see, the disease-free survival has improved around 10%, and overall survival has also improved around 10% with trastuzumab. So you may think that 10% is not going to be that much that much high. But if it is in a simple terms, it is easy to understand. It is easy to get marks from 0 to 70, but it is very difficult to go from there. From 70 to 90, 70 to 100, we have to work very much hard. So the same has been done by trastuzumab here. Already with chemotherapy, we can achieve a survival of around 70%. So if I give trastuzumab to my patient, I'm expecting around 80% of the survival. So for most of the patients here under Aarogyasri, we are adding trastuzumab and with chemotherapy. So for most of the patients, I'm expecting a survival of around 80%. And at some point of time, 20% of the patients are going to relapse. But I'm not satisfied with that 80%. So my heart wants more. I want to give more for that patient. I want to make her to survive more. So then what I have to do? So I would like to introduce here to a concept of pathological CR. See, pathological CR is one of an important biomarker in breast cancer, especially in an in the patient who are undergoing an curative intent. So pathological CR, like HER2, like ERPR, it is also going to influence the management of the patient. So here what happens is, if you open the net, if you put a pathological CR in breast cancer, you are going to see a lot of material. But I'm putting only one study here. Here, what they have shown is, we are nearly in around 9,000 patients. They have shown that if the patient who achieve pathological CR it means if you give a neoadjuvant chemotherapy, preferably complete neoadjuvant chemotherapy, means all chemotherapy cycles prior to the surgery. Then with surgery, if you see a pathological specimen in a surgery, there won't be any tumor. That is considered as a pathological CR. That is complete pathological CR if nothing is seen. If you are seeing anything, that is called as no pathological CR. So if you achieve a pathological CR in a patient, then here you are seeing the survival curves. That is event-free survival and overall survival. Event-free survival is similar to disease-free survival. And here you are seeing a nice separation of the curves. The red one is for the survival for the patients who achieve pathological CR, and the blue one is for no pathological CR. Means if you achieve a pathological CR, it is going to be a prognostic marker at this point of time, and the patients who achieve pathological CR are going to survive better. So for this patient, this 56-year-old lady, I want to achieve a better, higher pathological CR for this patient. And if you see here also, here if you see in the subgroup analysis, so another important thing is we have to see a subgroup analysis also for any trial. So here triple negative breast cancer patients, yes, pathological CR improved survival. For HER2 positive patients, it improved survival. And for hormone positive grade 3 patients, means higher grade, poor biology patients, for them also it improved survival. But for only hormone positive with good biology, it is not that much. The line is crossing the line of no significance. That means no benefit is seen. So then I want to achieve pathological. I want my patient to achieve higher rates of pathological CR, and and first, thus I want to improve the survival of the patient. So how I am going to do that one? With the so here I'm going to present you another trial. So we all know that if you add trastuzumab to chemotherapy, it improves survival. So now if you add another novel HER2 new therapy, that is called as an here it is P. P means pertuzumab. It is similar to HER2. It is similar to trastuzumab, but it will bind in a different domain of an extracellular domain of an HER2. And the important another important mechanism of HER2 is, apart from downstream signaling through the stimulation of HER2, it also forms an heterodimer with HER3. There are a lot of HER1, HER2, HER3, HER4. So it forms heterodimerization with HER3. If it forms an heterodimerization with HER3, it will activate again the similar downstream pathway. So it is one of the resistant mechanisms for HER2. So pertuzumab will inhibit that binding of HER2 with HER3. So it will act synergistically. You may get a doubt that why we are giving two HER2 new therapies upfront. But pertuzumab, it will bind at different site, and trastuzumab bind at different site, and both will act synergistically. That's why logically they combined trastuzumab with pertuzumab, and they gave with T here stand for docetaxel, C for carboplatin. So here we can see that, but the control arm is different. Here it is an trastuzumab emtansine. This is another different mechanism drug. So when I was doing my residency in Jipmer, my consultant used to tell why I took medical oncology. His name is Prashant Ganeshan. He is now HOD there. So he was fascinated about one drug called as gemtuzumab ozogamicin. So gemtuzumab ozogamicin is nothing but a drug which can be used in AML. So gemtuzumab ozogamicin is a drug where we can tag a drug to an antibody by means of a linker. The same way happens here. Trastuzumab is an antibody, and DM1 is an emtansine. Emtansine is an chemotherapeutic drug. We will tag this chemotherapeutic drug to an antibody by means of a specific linker, and by this mechanism we can deliver the drug specifically to the tumor cells, because HER2 new is expressed mainly on the tumor cells only. So like that, trastuzumab is going to work. Like that, TDM1 is going to work. So here they compared with TDM1 with pertuzumab, and most of if you give chemotherapy with dual anti-HER2 new therapy, we are going to achieve better pathological CR. So ideally for my patient, I have to give a dual anti-HER2 new therapy along with chemotherapy. With that, I can make her to achieve higher pathological CR, pathological complete response, and it is going to improve her survival. So this is the, if you see the subgroup analysis, only estrogen receptor positive, estrogen receptor negative, that means hormone negative, and HER2 new positive in those patients, because a patient can have triple positive also. All three can be expressed in the same tumor. So if a patient who patients who are having negative negative hormone status and only HER2 new positive, there the benefit is seen more. But irrespective of that, on intention to treat population also benefit is seen, and even in triple positive patients also benefit is seen. Currently, this is the standard of care in neoadjuvant therapy for patients with HER2 new positive with tumor size of more than 2 centimeters or node positive. And if you see the event-free survival here with the patients who received dual anti-HER2 new therapy and TDM1 with pertuzumab, there is an improved event-free survival with the chemotherapy with anti-HER2 new therapy arm. And another important take-home message here is, with pathological CR, even though if you give TDM1 with pertuzumab or chemotherapy with pertuzumab, those patients who achieved pathological CR, they have shown better survival. That is an important thing. So if this patient with pertuzumab, trastuzumab, carboplatin, and docetaxel, if she achieves pathological CR, then I'm happy. I don't want to give much therapy. If she doesn't achieve pathological CR, then what I have to do for her? So that is an important thing. This is because only 60% of the patients will achieve pathological CR. Around 40% of the patient will not achieve that one. So then another important thing is here for the patients who received neoadjuvant chemotherapy and then who didn't achieve pathological CR, for those patients, they received anyway standard of care is trastuzumab in those patients. And if those patients, if they receive TDM1, that is an antibody drug conjugate, so that has shown improved survival. And when compared to only adjuvant trastuzumab. So this is the way to go for this patient. I will give dual anti-HER2 therapy. If she achieves pathological CR, then I'm fine. If she doesn't achieve pathological CR, ideally I have to go with TDM1. But in our center, in our setting, cost is a problem with TDM1. So most of the patients end up with trastuzumab alone. Trastuzumab is covered under, even though it is a costly drug, it is covered under Aarogyasri scheme. And so this is the survival. Again, you know, it has shown 10% benefit. So this is she's a real, she's my patient. And so currently she is on trastuzumab plus pertuzumab and carboplatin with docetaxel she is getting. She has completed 2 cycles of therapy. She can afford pertuzumab. Pertuzumab is a costly drug. It costs around 2.2 lakhs for each therapy. So I am expecting a patch CR rate of around 55 to 60% for this patient. And once after completion of 6 cycles, she will go for surgery, followed by followed by radiotherapy. And if she doesn't achieve patch CR, I will counsel them for trastuzumab emtansine. If she achieves patch CR, I'll go with trastuzumab alone. This is how I am going to treat this patient. And coming to the triple negative breast cancer. So triple negative breast cancer is one of the worst malignancies, worst malignancies overall, and also one of the difficult to treat malignancies in breast cancer. So here is another, because the biology of the disease is more aggressive and it will become chemo resistant very fastly. So here here is another one of my patients. Is a 35-year-old lady with clinically T2N1 breast cancer, stage 2, with triple negative breast cancer. So how I am going to treat this patient? I want to show another how immunotherapy is going to act, because nowadays you are hearing lot of things about immunotherapy, but this video is again not playing. So I will show you in a slide. So here there is an important important mechanism in tumor progression that is called as an immune evasion. Immune evasion means if there is if a tumor is there, that tumor will be detected by our immune cells. They are called as there are a lot of immune cells are there. T cells, NK cells. They will detect those the tumor cells and they will kill those tumor cells. But tumor cells are so intelligent. They will develop certain mechanisms to evade this mechanism. That is called as an immune evasion. And immunotherapy is one of the kind of therapies that will help our immune system to kill the tumor cells. So here one of that mechanism is PD1 and PDL1. This is a T cell. PD1 is programmed death 1. PDL1 is programmed death ligand 1. So PD1 is expressed on the T cells, whereas PDL1 is expressed on the tumor cells. When this PD1 interacts with PDL1, then the T cells will not recognize the tumor cell as a foreign body and it will not kill the tumor cells. But what these drugs like pembrolizumab, nivolumab, whereas PD-L1 inhibitors like atezolizumab, durvalumab, avelumab. So what they will do is they will block this interaction, thus activating the T cells to kill the tumor cells. So that's how these immune cells are going to act. Actually, this is an really old concept. Actually, this similar concept will be there in allogenic stem cell transplant also, which we call it as a graft versus leukemia effect. So here it was somewhat sophisticated, but that was a old one, which was invented during 1980s, around that time. So like this, immune therapy is going to act. And this now we are seeing a lot of advances in immunotherapy. Like we are seeing an adaptive T cell therapy, like another CAR T cell therapy. All of these are advances in this thing. Then an important thing with triple negative breast cancer is there is going to be an increased expression of this PDL1 or PD1, which we are going to see by means of an immunohistochemistry. So if there is going to be an increased expression, if you logically, if you add a drug to that, if you add a drug which is going to target that one, then there is going to be an improved outcomes. So here is another study which has shown that if you add pembrolizumab to chemotherapy, that chemotherapy they have used a standard chemotherapy, that is paclitaxel followed by doxorubicin with cyclophosphamide, but here they have added carboplatin also in the neoadjuvant chemotherapy. So if you add that chemotherapy to pembrolizumab, there is going to be an improvement in a survival. That here they have mentioned as an event-free survival, around 10% benefit in the event-free survival. And the same thing is important is pathological CR also improved by 15%. 15% along with the improvement in an event-free survival. So if a triple negative breast cancer patient with a tumor size of 2 centimeters or more, I would like to go with neoadjuvant chemotherapy along with pembrolizumab. But more again, the same problem comes, especially in our Indian scenario, that is the cost. So here for some of the patients, similar to pembrolizumab, there is another drug called as a nivolumab. Nivolumab is also an PD-1 inhibitor. Logically, both acts at the same level, and both will be having an same responses also. As a clinician point of view, trials may show differently, but a lot of data is shown that both will act similarly. And the important thing with pembrolizumab or nivolumab is, if you see in phase 1 trials or phase 2 trials where we are going to assess the dose of the drug and toxicities of the drug, there is no specific dose there is no defined dose at which this drug is going to be efficient. This drug is not going to be efficient. We can go as low as 0.6 mg per kg and the recommended dose of 3 mg per kg. So here, basing on this concept in Indian scenario, the way is to go with low dose strategies where it is going to be cost effective. Here at our center, we are using nivolumab at 40 mg. Ideally, that the recommended dose is 3 mg per kg, but we are using a 40 mg flat dose for some of the head and neck patients. So, but ideally, the nivolumab is also very costly drug. 140 mg costs for about 1.4 lakhs, and pembrolizumab also costs 200 mg 1.5 to 2 lakhs. So the way to go in our setting is to go with a low dose strategies that has to be backed up by a sound clinical data or sound clinical studies. And another thing is drug repurposing is another way to go in our setting that will be beyond the discussion of today's topic. So for this patient, ideally has to go this one. And if you see the subgroup of all TNBCs also here, the benefit is shown in almost all subgroups. It is not, we cannot say that one group is not benefiting, other group is not, other group is benefiting. The benefit is shown in almost all subgroups. So if the patient ideally has to go with pembrolizumab and neoadjuvant chemotherapy, then but another important thing in our setting is we don't have access, as we don't have an access to these newer drugs, we can use the old drug in a new fashion, that is carboplatin. So carboplatin here in triple negative breast cancers, it has shown to improve pathological CR rates if you add to a neoadjuvant chemotherapy. It is partly maybe because triple negative breast cancers are having a higher incidence of BRCA1 and BRCA2. BRCA1 and BRCA2 are germline mutations, like mutations at the level of the gene, which can result in breast cancer, ovarian cancer, these things. So BRCA1 and BRCA2 are highly sensitive to platinum-based chemotherapies. That's why some of the ovarian cancers will respond exceptionally better to chemotherapy with the platinum-based chemotherapy. So, these studies have shown that there is, irrespective of BRCA, there is going to be an increased pathological CRs if you add carboplatin to an neoadjuvant chemotherapy. So here, what we are practicing is for the triple negative breast cancers who I think they are going to tolerate the toxicities of the chemotherapy. We are adding carboplatin to an upfront setting after adriamycin cyclophosphamide with paclitaxel with carboplatin. So another, as I mentioned about BRCA1 and BRCA2. So if this patient after receiving the neoadjuvant chemotherapy and she underwent surgery, and what I have to do if she had an pathologically she had no pathological CR. So in that thing, so as this patient will be having a higher incidence of BRCA1 and BRCA2, that is a germline mutation. There is a difference between germline mutation and a somatic mutation. Somatic mutation is what we are going to take in tumor tissue, and we are seeing that this patient is having an mutation present or not. But germline mutation is not like that. We will take an it will be present in almost all the tissues. We'll take a swab from oral swab, and we will check, or we can check the blood of the patient. So in those things, we will check whether the BRCA mutation is present or not. So germline mutation is important because for the familial counseling, if there is an only somatic mutation, familial counseling is not needed. There is no increased incidence in the families. But if there is an germline mutation, there is an increased incidence in the family members also. That is also one of the prognostic information which we are going to get from the type of mutation test, the type of test we are ordering. So here, if the patient is having a germline BRCA mutation and triple negative breast cancer, and she doesn't achieve the pathological CR, then I would like to go with an olaparib. Olaparib is an PARP inhibitor which acts by an synthetic lethality. You can go and check that mechanism of action. It is going to be a very interesting mechanism of action. And this has revolutionized the treatment of ovarian cancer and BRCA positive cancers. And the most important thing is we are going to, when I started my DM, at the time, if you see an hallmarks of cancer, there are only 10 hallmarks of cancer. And now there are 12 hallmarks of cancer, and BRCA mechanism is newly added hallmark of cancer in that one. So if you give the BRCA inhibitor, olaparib, there is going to be again improvement in survival by around 10%. So if this page, I would like to give pembrolizumab plus chemotherapy, and she doesn't achieve pathological CR, I would like to go with, I would like to check with BRCA1 present or not. If BRCA1 is present, I would like to go with olaparib. Otherwise, I would keep her on. I would like to keep her on. If she achieves pathological CR, I would like to keep her on observation. But olaparib is again the same problem with our. This is the subgroup analysis, and if you see the same thing with pembrolizumab, every subgroup is benefiting. If the germline BRCA mutation is present and no pathological CR, yes, the way is to go with olaparib. Then another important thing is this. The same problem is with the cost. Olaparib is again the most costly drug, one of the costliest drugs available currently in the market. So in our setting, whether I can do better for my patient or not. So there is another important study called as an CREATEX trial, where they used capecitabine, which is one of the anti-metabolite chemotherapeutic drug. So they used capecitabine, adjuvant capecitabine in those patients who didn't achieve the pathological CR. And this adjuvant capecitabine has improved the survival in these patients. So the patients who didn't achieve the pathological CR, in our setting, yes, we can go for capecitabine alone. Those who cannot afford the olaparib, and those who doesn't have BRCA1 and BRCA2, we can, in those patients, we can go for adjuvant capecitabine for 6 months, and it shows improvement in survival. Then again, you have seen a lot of these images. Anyone say, what is this one? What is this image called? It is called a forest plot. And the central line is called as a line of no significance. And this is the small square is called as a population size. And this one, the confidence interval limit. This one is the confidence interval limit. And the base one is shows if it is crossing the midline, means it is usually not significant. And if it is the other side, then it is significant. If it is opposite side, then it is not going to benefit the patient. So for this patient, I would like to go with, if she can afford pembrolizumab, I will go with pembrolizumab with the carboplatin-based chemotherapy. If she doesn't afford pembrolizumab, I'll go with neoadjuvant chemotherapy incorporating carboplatin for her. And then I am expecting a path CR of around 60 to 65%. It is a little bit better than HER2/neu. And if after surgery, she achieves pathological CR, then I like to keep under follow-up. And if she doesn't achieve pathological CR, I would go with an olaparib or capecitabine basing on the BRCA status. Thank you. And another important thing is I want to show this way of using the old drugs in a different setting. So here capecitabine has been used in an adjuvant setting, and in an adjuvant setting in the patients who has received either adjuvant therapy or who has completed the entire definitive treatment. That is, chemotherapy, surgery, and radiation. In those patients, they have used the chemotherapy, that is capecitabine. Capecitabine has been indicated for breast cancer, and it has been used in metastatic setting. But here they have using this old drug in an adjuvant setting to improve the outcomes. These are kind of the studies which are going to help to our patients, where they are going to get a more benefit, as these drugs are relatively cheaper and easily available, and we know those toxicities of these toxicities associated with these drugs. So here addition of capecitabine, irrespective of PAT-CR or irrespective of anything, post therapy they have given capecitabine for 1 year, and they have shown improvement in survival of about 10% improvement in an disease-free survival. So, so in this triple negative breast cancer and HER2 new positive breast cancer, these are aggressive tumors. We have to be on our toes while treating them. But whereas hormone positive breast cancer is not like the biology of the disease is somewhat different. It is a slowly proliferating tumor, but it is also quite heterogeneous, but it is a slowly proliferating tumor. So in these patients, we came up with a newer concept. That is, we can find the patients who doesn't need chemotherapy, and we can find the patients who needs the chemotherapy also. So here is another patient, which is one of my patients. She's a 55-year-old postmenopausal lady, and with no high risk features on the path and post surgery. That is, size is small. It is a low grade tumor with higher ER/PR expression, and Ki67 is also low, and HER2 new is also low. So how I am going to treat this patient? So here this is called as a somewhat Taylor-X study. Here we are going to tailor the therapy for the patient. So these low risk patients, they have done for some of 3,000 odd patients, they have done a test called as an oncotype DX. That is an genes, oncotype DX is an something like a next generation sequencing. So where they have done is, they have done an oncotype DX, and they have given a score to those patients, to that score, to that test. So if the patient is having a score of less than 10, in those patients, they found out that there is no benefit of adding chemotherapy. And if the patients are having a score of more than 25, so those patients are the ones who are going to get benefit from the chemotherapy with endocrine therapy, that is an hormonal therapy. So what we have to do with this 11 to 25 score patients? So this question has been answered in this trial. So they have they have randomized the patients to chemoendocrine therapy versus only endocrine therapy. And in those patients, they have found out that if the patient is having an 11 to 25 score and there is no any risk factors, and among those patients, addition of chemotherapy didn't add much benefit to these patients. So there is ideally, for these patients, we are giving more to those patients. If you are not able to perform this test, we are going more therapy to some of the patients, and we are giving toxicities to those patients. So if you remember, if you would have seen the toxicities of chemotherapy, then you can understand how much problem it is going to be for the patient. Because simple neuropathy, they are not able to sleep during the night because of that pain. It is going to be very toxic to give chemotherapy. So these kind of studies are also needed in our setting. But the problem again is, we are going to have this cost of this test. This test is going to cost around nearly 1 lakh, where patients are happy to go with the chemotherapy, where they can get the chemotherapy for free, than to go to this test. So, but we can use other surrogate markers like the ERPR, like which I have shown previously, how much expression of ERPR is there, and what is the Ki67 score, what is the age of the patient, whether she is really postmenopausal or not. So all these things we have to in the clinical. Currently, when I'm sitting in the clinic, I'm assessing all these criteria and discussing with the patient whether to go with whether only endocrine therapy or chemotherapy alone, chemotherapy with endocrine therapy. But ideally, the way is to go with this score, and the way to go in our setting is to collectively take all the information of the clinical pathological data. Then, if you are not able to perform this costly test, then another important thing with endocrine therapy is till how much duration we have to give the therapy. So previously it was for 5 years. Now it has been extended to 10 years. 10 years has shown improvement in survival in these patients. But the problem with if you are going to give 10 years of letrozole or anastrozole is, can anyone guess what are the problems which you are going to get with anastrozole and letrozole? So if you give letrozole with anastrozole for most of these patients, there is going to be their bone density is going to be decreased. If there's going to be a decrease in bone density, then there is going to be a higher risk of fractures. We have to keep in mind that these patients are elderly patients. Most of the cancer patients are elderly patients. And if they are going to have a higher risk of fracture, then there is going to be morbid to the patient and morbid to the family. So we have to keep all these things into consideration. So here they have randomized the patient for 2 additional years of aromatase inhibitors at tamoxifen. And another one is 5 years. And they found out that there is no much difference. In fact, if you are giving if you are giving 3 more years, there is going to be an increased risk of fractures. Risk of bone fracture is higher here. The orange one is for 8 years and the blue one is for the 7 years of therapy. So it is not always more is better. It is going to be giving an ideal therapy and identifying the correct treatment for the right patient is going to be the way for the for most of the malignancies, and the same is the way for the breast cancer. And while you are interpreting that study, the most important thing is you should not take everything as it is what I am telling. You have to see, you have to read in between the lines. So here, if the patient of similar characters with the node, if the patient is having on more than 4 nodes and means higher risk disease, there you can see that benefit is not seen. So we have, while interpreting the data, we have to be very much clear. And so if the patient is having an less than 3 nodes, I would like to go with 7 years of therapy. And if the patient is having more higher burden disease, still I'll go over for 10 years of adjuvant hormonal therapy. So the same concept of the previous trial which I have discussed, that trial has included BRCA positive is expressed irrespective of whether it is an TNBC or whether it is an hormone positive or whether it is an HER2 positive. But the incidence of expression is going to be higher in TNBC, followed by hormone positive, followed by HER2. So here the same thing. Here, apart from so for example, some of the patients of hormone positive patients will locally advanced disease or where surgeons feel that they need a neoadjuvant chemotherapy. So in those patients have received neoadjuvant chemotherapy here. And if the patients, apart from not achieving pathological CR, they have used another score also, that is an pathological score. Then they based on that pathological score, they have used that adjuvant. If the patient is having an higher score also, in those patients they have used olaparib and they have shown improvement in survival. So this is how we are going to move in the future. So if for any malignancy, so this is called as a response adapted therapy. So with initial therapy, what is the response, and basing on the response, how we are going to treat adjuvantly. So this is called as response adaptive therapy, and this one we have taken from the leaf of an Hodgkin's lymphoma, where we are using an PET-CT as a response adapted therapy. Here we are using the PAT-CR as a response adapted therapy. And I didn't touch this topic of CDK4/6 inhibitors. So these are also newer drugs. CDK4/6 inhibitors have been approved for hormone positive breast cancer in a metastatic setting. It has shown improvement in survival when compared to hormonal therapy alone. So here it is coming forward into the adjuvant setting also. These CDK4/6 inhibitors, they will act, if someone remembers the cell cycle, CDK4/6 is one of the important machinery that is requiring for the cell to progress. So these are the drugs which are going to inhibit that one. So when you add endocrine therapy with abemaciclib, it is one of the CDK4/6 inhibitors. Here at our center, we are using ribociclib for metastatic setting. But this abemaciclib is all are costly drugs, but we are using ribociclib under EHS. So this abemaciclib has in this high risk patient, it has shown improvement. This 3%, we can say it is not that much benefit. But they have included a lot of patients, and to show this amount of benefit 3%, and it is to our discretion whether this benefit is going to be clinically meaningful to the patient or not. Statistically significant doesn't mean that it is going to be a clinical benefit. If it is going to be clinical benefit, that one we have to take. So still this is going to benefit some of the patients. So this is about the curative setting. Just a single slide about the metastatic setting. This is how we are going to treat metastatic cancer. So in hormone positive, we are going to add endocrine therapy with CDK4/6 inhibitors in the first line setting. In the second line setting, if they are progress, we have to see by PCR whether there is an PIK3CA mutated or not. If it is mutated, we have to go with fulvestrant plus alpelisib. If it is not mutated, then we can go with single agent fulvestrant or a combination of exemestane with everolimus. And with the third line chemotherapy, and then there is another antibody drug conjugate that is called as an sacituzumab govitecan. It can be used. And another important concept I have to tell here is HER2/neu. So HER2/neu as an IHC, we can see that 3+ is considered as positive. If it is an 2+, that if pathologists report, the scoring is given as 1+, 2+, 3+. If it is 3+, it is positive. If it is an 2+, in those patients, we have to confirm by means of an FISH, that is fluorescence in situ hybridization, whether it is amplified or not, we have to confirm. Then if it is amplified, that will be taken as an positive, and we are going to give an anti-HER2/neu therapy in that setting. And if it is an negative on FISH, or if it is an 1+, then we usually will take it as an negative. But here there is another newer drug called as an trastuzumab deruxtecan, where in these lower expression patients, that is 1+ patients, if you use this drug in a third line setting, that has shown improvement in survival. So the way we are interpreting the lab results, and the way we are using the newer drugs is rapidly evolving. So now today, what I'm telling may not be true tomorrow, because the field of oncology is rapidly evolving, and because there is a lot of need in this setting, and because we have to improve, we have to give more to our patients, and also there is an increase, many advances in the understanding of the disease. So, and in HER2/neu, there's trastuzumab, pertuzumab in upfront setting. In second line setting, trastuzumab deruxtecan is approved. Previously, it was trastuzumab emtansine. And there is I didn't tell about TKs that are going to inhibit the HER2, because till now I told about monoclonal antibodies only that are going to inhibit HER2. There are TKs also that are going to inhibit HER2. So monoclonal antibodies are the one which are going to act at the extracellular domain of the receptor. Means if you give a drug, that will go and bind to the extracellular domain of the receptor, means outside the cell surface. What this TKS means tyrosine kinase inhibitors. The prototype of TKS is imatinib. That was the first TKS that was discovered. So these TKS will go through the cell membrane, and they will these all receptors will be having an ATP binding site. There, these drugs will go and bind, and they will inhibit the downstream signaling pathway. So that is how these drugs will act. So there are a lot of TKs in HER2 also, lapatinib, which can be used in metastatic setting, and we are using for some of our few patients. And neratinib, tucatinib, there are a lot of drugs. So we are going to see a lot of new drugs in this setting. And triple negative breast cancer, this is one of the worst cancer to treat. And yes, pembrolizumab as in the adjuvant, in the neoadjuvant setting, pembrolizumab has improved survival in the first line setting also in metastatic. Then in the second line, chemotherapy is still there. And in the third line, we have to go with sacituzumab govitecan. So take home messages. So we are seeing all these advances mainly because of better understanding of the disease, which was partly by means of an novel technologies also, like next generation sequencing, pathological polymerase chain reactions, and FISH, and better advancements in immunohistochemistry. So the recent advances at the molecular level and recent advances at the systemic therapies will go hand in hand. Both will go parallelly. And second important take-home message is neoadjuvant therapy is going to be the way to go away in the, especially in the triple negative breast cancers and HER2 positive breast cancer, where there is one is PAT-CR rates, which is going to be prognostic, and we can modify the therapy, adjuvant therapy, basing on the response rates, which is called as a response adapted therapy. And the novel drugs like addition of pertuzumab, pembrolizumab, and using the old drug carboplatin has improved the pathological CR rates. and it is not, it is always more is not going to be the way for most of our patients. We have to tailor the therapy according to the patient clinical features, patient disease biology, and their financial needs. Any questions? Any questions? I'm happy to take.
Apart from this recent advances in the medical oncology, for the PG sake, can you please simplify depending upon the stage and depending upon the biology, ERPR and HUR2 status? Can you give a simple guidelines so that while presenting a case, they can confidently tell that for this stage, for this thing, this is the treatment?
So for first we'll come to hormone positive. So hormone positive, they can go with neoadjuvant chemotherapy basing on the, this is the surgeon's opinion, whether they have, whether they need an neoadjuvant chemotherapy or not. So if they are not, if they are feeling that it is not going to be operable upfront, or there is going to be cosmetically difficult for the patient. So for hormone positive patients, it can be an neoadjuvant chemotherapy or upfront surgery. Both can be the way. Neoadjuvant chemotherapy followed by surgery, followed by adjuvant, followed by PMRT basing on the indication for PMRT, followed by endocrine therapy. This is going to be the way for the hormone positive. If we are going for upfront surgery in hormone positive patients, upfront surgery followed by indication for chemotherapy. Usually if it is less than 1 centimeter, we tend to avoid chemotherapy. So if it is more than 1 centimeter, we would like to go with an adjuvant chemotherapy, followed by, if it is an indication for PMRT, then those patients has to go for PMRT, followed by endocrine therapy. This is going to be. But for HER2/neu and TNBC, if there is, they are having a node positive and the size of the tumor is more than 2 centimeters, we would like to go with a neoadjuvant chemotherapy. This is simply because of the prognostic value of the pathological CRs, and there is going to be we can modify the therapy in an adjuvant setting. So that is the reason why we want these early breast cancer patients also to go for an neoadjuvant chemotherapy. Then the principles is going to be the same. If you're going to give a neoadjuvant chemotherapy, that is previously we used to give chemotherapy before and after surgery, but now we would like to go with a complete neoadjuvant chemotherapy followed by surgery, and followed by basing on the response, we have to modify the adjuvant therapy. So that is the thing. So that is going to be the way for the for HER2/neu and TNBCs. So I would like to ask you one thing. So what is your opinion on pathological CR, evaluating the pathological CR on surgery or evaluating a pathological CR on an imaging, which is by MRI? So this is very important because you are going to see these things in the future. So it will, if you are going to see an pathological CR on an MRI, now it is coming up, then most of the patients may not need surgery. Ideally, if you see an pathological CR, maybe those are the patients may not need need surgery. These data is coming up in the, we are going to see that data in the future in maybe 3-4 years. The same has been the case as in rectal cancer. So in rectal cancer, recently we have a study with neoadjuvant immunotherapy. That is, they have used dostarlimab in that setting, where they have seen a complete path CR rates, and those patients didn't undergo for surgery, and those patients are still following up, and they for past 1 year, and they didn't have progression. So the same thing can happen in breast cancer also, and it is at the phase 2 trials are going on with evaluating the pathological CR by means of MRI, and those patients are not going for surgery. So this is going to be the way. Maybe some of you don't like that one, but we are going to see in future some of the patients of breast cancer may don't need surgery also.
Thank you for the talk, sir. Very informative. Now I'd like to request Dr. K. Srinivasa Rao, sir, Associate Professor of Department of General Surgery, to kindly honor our speaker. I also request Dr. Venkat Hari, sir, to kindly honor the speakers. Can someone switch on the lights? Thank you, sir. Thank you, sir. Our final speaker for the day is Dr. Sindhu Priya Garu, Assistant Professor in the Department of Plastic Surgery, Narayana Medical College. Ma'am has completed MBBS from Narayana Medical College in 2005 batch. She did a DNB plastic surgery from Apollo Hospitals, Chennai. She worked as a consultant in Narayana Medical College from 2020 to 21. At present, she is the Assistant Professor in the Department of Plastic Surgery, Narayana Medical College, Andhra Pradesh. I'd like to request Dr. Sindhu Priya Garu to proceed with her talk.
Good afternoon to everyone. I'm Dr. Sindhu. I'm very bad for my sore throat today. Okay, I'm very happy and very privileged to be here and talking in front of my teacher, sir. And also, I'm very happy that Mahida sir and Chaitanya sir just gave me a call to give us a talk on the reconstructive options which has been there used for the post mastectomy defects. Sorry. So what is the role of a plastic surgeon in mastectomy? I mean, in an oncological perspective, what is the role of the plastic surgeon? We have only two things which needs to be solved. One, after a mastectomy, if there is any skin defect which needs to be covered, that is a definitive thing. Because if for suppose if the skin flaps are not good and there is a wide local excision where the skin closure is not possible, definitely needs a flap cover. The other thing is a cosmetic purpose. Now, I mean, compared to the olden days, now the generations they are very, very, the thought process is evolutionized. They say that, okay, they need each and every aspect of their body that needs to be proper. So because of the socialization, they are more worried about the cosmetic correction post mastectomy. The important point is that even though if you do a reconstruction, it's not going to do any functionality of the breast, you are not going to retain any functionality. The only thing is that we are going to give you a very reliable skin cover. And the second thing is that we are going to give a cosmetic outcome to the female patient. Because after mastectomy, the oncology, that the term of the oncology happens in a family member, not only the affected person, the entire family members will be shattered. That is the initial stage that is going to happen. So in order to build up the confidence levels of the patient, the cosmetic reconstruction would help them in gaining their, it helps to give a boost to them. So as I told you, the patients are really very fragile at that condition when they are being diagnosed with the malignancy. And so we being an oncology specialist, maybe a surgical oncologist, or medical oncology, radiation oncology. So we are in a persons that we need to guide the patients. It's a multidisciplinary approach. We need to guide the patient that, look, this is the condition and this is the stage in which your breast cancer is there. And these are the options available. and maybe whether you need to go for a mastectomy or a chemotherapy. And for suppose if there's a mastectomy happen, so these are the problems which can happen after mastectomy, and these are all the wide options which are available in order to get the shape of the breast contour back. And we had to discuss all the options, and I had to give the best shot to the patient. Yeah. So what are the reasons for reconstruction? This talk is only regarding the cosmetic purpose I'm talking of, not for the definitive reason. So what is the reason for reconstruction is, yes, in order to get rid of an external prosthesis. And it inhibits the clothing limitations for a female. If their breast, if for suppose having a unilateral breast mastectomy being done, it is really very difficult for them to have their maybe the dress. There will be a lot of limitations. They had to hide with some sort of shawl or something to hide that. So that is not a good quality of life which we can provide. So it helps to regain the femininity of the patient, and the patient also will get a emotional support, and it can improve maintain the marital and the sexual relations. And there is a lot of taboos which have been there in breast reconstruction, which being a budding surgeons, we should know that we should overcome all this. And so we have to explain to the patients that they have a lot of fear. There will be a lot of fear of complications. Okay, if I get a breast reconstruction done, what might happen? They're taking a tissue from somewhere else or putting it somewhere else. What can happen? So there's a complication. They have a lot of fear of complications in their mind. That needs to be cleared off before we are taking up the patient for any reconstruction. And many, I mean, compared in our Indian society, they say that once the female crosses 30, they say that, okay, I'm done with my family, I'm old enough, I don't want any sort of cosmetic procedures. So that is not that thought process is that will hinder us from getting a reconstruction done. As I told you, they're not aware of all the procedures. Okay, and they feel that, okay, I just got an malignancy is there, I just want to get rid of, chop off that the malignancy, and I don't want any sort of any other surgeries. And they are fear that they can it might even cause malignancy, or it can mask my malignancy because you're putting some sort of tissue over my breast. So these are all the things which will be running in the patient's mind. So we need to clear off all these the obstacles which we come across before we are planning for any reconstruction. Yep. So when the patient is okay, then the patient says, okay, doctor, I'm ready for the breast reconstruction. So we have to evaluate the patient. So we have to ask for the patient that what are your realistic expectations. This comes most common in a very young woman who had a mastectomy done. This is, for suppose, this sort of the expectations will be more in case of mostly in a non-malignant lady when she approaches us for an breast reconstruction. So they have a very high expectation. They say that I want such a big breast, maybe a D cup or C cup. So that all comes for the non-malignancy. So, but even in a malignant condition also, we have to explain to them that what are your expectations, and where you need a very small breast, you're happy with the small breast, means we can go and get rid of with the LD flap. Or we say that, no, madam, I just want a breast which is very symmetrical to the other breast. Or suppose it's a larger breast, then you have to go for the other options. So a proper oncological workup is very important, and the family history and the previous abdominal and thoracic surgeries. Why we are looking for abdominal and thoracic surgeries is that we need to check for our donor areas. That means from where we are taking the tissues, whether taking a tissue from the abdomen, or we are taking the tissues from the thoracic or the thigh or the gluteal region. So from the top to bottom, we need to examine the patient and need to check that what is the quantity of the skin available, whether there is any surgeries being done, or there is any scars are there. These are all the things which we need to evaluate the patient before taking up for reconstruction. And if it is an young lady, she's planning for any future pregnancy, then also we had to ask about the future pregnancy plans also, because when you're taking an abdominal flap, that's gonna be issue with that. So what is the name? So now we know that what all we need to evaluate and all. So now what is our aim? Yeah. So in order to provide a breast contour, this is the prime motto. And in order to achieve a symmetry, and so that the patient, we need not use some sort of external prosthesis, maybe a padded bra or a padded some silicone sticky thing, that all things which needs to be avoided. And you have to re-establish the normalcy and the confidence of the patient, which will greatly improve the quality of the life of the patient. So, yeah. So the preoperative evaluation, apart from the oncological and the general examination, what being a plastic surgeon, we are much concerned about. As I told you, the abdominal examination, and after the, sorry, after the resection, we had to look at the what is the size of the defect, which is there after the resection, which how much of skin needs to be replaced, and the position of the scars and incisions. In plastic surgery, we are very we think a lot before putting a knife. We feel that okay, we'll make a scar in such a way that it's concealed. For suppose we are doing an abdominoplasty, you are doing a tram, or you're doing a gluteal flap, we will make in such a way that the scars will be on the hidden areas. And we should make in such a way that we should utilize the scars which has already been done for the mastectomy. And the important part is that we should know about the skin viability. How is the skin viability, and how is the quality of the skin of the mastectomy skin flap? This is also very important. And if the pectoral muscle is being retained or not, that we have to check. And if there is any sort of post radiation, whether there is any post radiation changes, or whether there is any scar being tethered to the chest wall, these all things which needs to be evaluated properly before. And the radiological examinations in the sense that I will just come back to you. If you're doing a perforator based flap, I'll tell you, because you guys are not aware that you guys will not be aware of what is perforator, and I'll just give a small talk on that. So you need to pre-operatively hand Doppler, or you can do a CT angio and look at the perforators from where, from the perforators are the vessels which will pierce the fascia and will supply a part of the skin. That we needs to be pre-operatively Doppler, so that it will make our easy job easy. Yep. So this is the patient which is having a unilateral mastectomy done. As I told you, you have to examine for all the donor areas, the abdomen, the skin. Look, this is a quite pretty big breast. So we had to think that whether we can I able to take this abdomen, well, this will be sufficient to, so that I can put it over the other breast and it will going to match it or not. Or she got a pretty broad hip, maybe a gluteal region would be more. So whether can I use that? That we need to properly examine the donor areas. Apart from the mastectomy, I mean the deceased breast, we had to look out for the opposite breast also. We had to look for the dimensions. We had to look the inframammary fold. Because this is some sort of ptosis is there in this breast. If you lift the breast, you can see some sort of a fold from the breast and to the abdominal skin. That's called inframammary fold. That we need to be marked. And the nipple areolar complex, where it is, where the nipple is pointing, and whether, as I told you, whether there's any ptosis or not, and whether the patient is willing to get an opposite breast, any other procedures to be done, so that both the breasts are going to look at a symmetry. So now the patient is ready. They said that, okay, I just want to get a reconstruction done. Then they said that, when can we do the surgery? Whenever you do the surgery, you should never ever compromise on the oncological point of view, perspective. That needs to be clear, because we can't keep on digging our graves. So the oncology should be clear, then we can go with the reconstruction. So when we have an immediate reconstruction, what is the main advantage is that it is technically it's pretty easy, because already mastectomy flaps will be there, the anat will be very good. You can see all the things everything will be laid open. The planes will be clear. And after the mastectomy, we can easily estimate the tissue which has been taken off. And we can even weigh the tissue and we can say that, okay, this is the amount of tissue which is lost, and from where we can replace the same amount. And it, as I told you, it's easier to reconstruct the inframammary fold, and it's a single surgery. The patient comes with the breast and goes off with the breast. And it's a desired goal is achieved sooner. The main drawback is that the skin flap. You had to assess the skin flap thoroughly, that there is the, what about how is the dermal bleed? If you want, you can take in 1 centimeter margin of the mastectomy skin also. We can even access if you are really very doubtful about the mastectomy skin flaps. So it is a two-team approach, and the drawback is that it is an we don't know about the surgical margins, the tumor pathology, and it can, if there's, for suppose we did a flap cover and there was some sort of flap necrosis, there is some raw area, so that's going to be it's going to delay the adjuvant therapy, and the sentinel nodes are unknown. So the delayed reconstruction is done after 6 to 8 months of adjuvant therapy. And the pros is that it's completion. The patient will come to us with an oncology, the disease-free condition in that area, in that time. And we have a definitive skin margins. But the drawback is that it's going to be technically challenging, because all the tissue, there will be a lot of fibrosis, there will be a lot of scarring being happening, and the creation of the inframammary fold, everything will be difficult. So we had to compare with that of the opposite breast, and we had to mark it, and we had to create a planes and all to reconstruct the breast. Yeah, this is one of the example for the skin necrosis, post mastectomy skin necrosis. So as I told you, vascularity assessment is very essential. So these are the basic things which can be we offer for a breast reconstruction. One is the prosthesis. As I told you, something like an external devices, like how we put after an amputation, how we put an amputee part, how we put an prosthesis. The same way you can use it for prosthesis. You can a silicone sticky thing. It comes around some $4,000, something like that. You can just put it on that, and she can wear her dress, or she can use an as I told you, the padded bra. She can use it for the cosmesis. Another thing is an alloplastic reconstruction and autologous. Alloplastic is that we are using some sort of material that is an implant based. We can use an implant based with or without an expander. For which sort of patients we use an implant based, that is the thing which you need to know. It is done in for suppose there's only a cosmetic deformity is there, and there is no any radiation being done pre or post the surgery, then we can go for an implant based reconstruction. For suppose if there is no enough mastectomy, mastectomy skin is there, then we can use a tissue expander. Tissue expanders are that something like an deflated balloon, deflated plastic bag, which when we can make it through we can put it into the underneath the skin flap, and you can weight it, and there will be a small port. I'll just show you. There will be a small port. Through that, with frequent intervals of time, maybe 15 cc per week, like that, we can keep on increasing the capacity of you can keep on inflating the tissue expander. Just like how you put an air into the balloon, we just put in a saline into that plastic bag. And within a due time, what happens is that there will be a lot of capacities for each expander. Depending upon the size of the breast, we have a different size of shapes, and also the size of the expanders, which we can place, and slowly we can inflate it. Once we attain the achieved, we have achieved our maximum expansion, we can take it out, then the skin will be nicely expanded, then you can put an implant. Just like how an multi-gravid lady, if she has a multiple pregnancies, how the skin will be lack, the same way, the same principle is been used in a tissue expansion. And this is the autolog. Sorry. So this is the autologous. Autologous means we are taking a tissue from somewhere else and putting it to the desired defect. We have, in general, plastic surgery, flap is a thing which is having a skin with a subcutaneous tissue. It is carrying its own blood supply. And the graft is, there will be nothing. There will be just a sheet of skin, that's it. So we had to know the differences between the skin graft and the skin flap. So flap means it's having its own blood supply. And in plastic surgery, we have various types of flaps based on from where we are taking. For suppose we have a local flaps. Local flaps in the sense, the flap is the skin is taken, which is very adjacent to the defect, which we can do here, but it limited to the very small defects. We can use that. Other thing is the regional flaps. For suppose the breast is this thoracic region, so we can take something like from the thoracic region. We can use an LD, latissimus dorsi. We can use that is a regional flap. For suppose we are taking it from a different area, so a distant area, like we are taking an deep inferior epigastric perforator based flap. This is over the lower tummy. We are taking it here. We are taking it with the vessel and we are taking off the vessel and we are keeping it here, the skin, the flap over here, and then we are anastomosing the vessel with the internal mammary or a thoracodorsal vessels over here. That is called as a microvascular flap or a free flap or a distant flap. So these are the basic things which you need to know, because I'll be keep on talking about them. And one more thing is the perforator concept. Perforator concept is that we have a main pedicle. I mean, main vessel will be there. The main vessel, as it goes into courses of as it courses down, it uses multiple branches. So once from the multiple branches, again there will be a lot of twigging happening. So what happens is that once this vessel it will goes and it will pierces the fascia, that will perforate and will go up and it will supply a certain amount of skin pattern. So that is called as a perforator. So as I told you previously also, we are doing a CT angio or an handheld Doppler in order to locate that perforator. If you look at that perforator, based on that perforator, we can track it down. Just like we are in a tree, there will be a lot of twigs and branches happening. We'll trace out one branch and we'll come down to the main thing. So this will be the basic concept for your microvascular dissections. So what are the options which we can use for the breast reconstruction is LD, latissimus dorsi flap. These are all the perforator flaps which I'm talking about. But even in LD, there's a lot of variations happening. We can use even a thoracodorsal artery perforator flap also can be done in this area. As I told you, deep inferior epigastric. This is the superior gluteal artery flap, inferior gluteal artery flap, the transverse upper gracilis flap. So these are all the various types of donor areas which we can utilize based on our requirement. These are all the tailor-made. We can't say that, okay, for this defect, this flap, and we can't tell it. So it's all tailor-made. So this is what I'm talking about the microvascular reconstruction. We can use any flaps. If we are dissecting it till the main pedicle, we can get a good caliber of vessels so that we can take off, we can transect that level, and we can re-anastomosis it at the desired area. So we can take a tram, latissimus dorsi, gluteal flaps, lateral transverse thigh flap, anterolateral thigh flap, superficial inferior epigastric flaps. As I told you, perforator flaps. Most commonly, we use a DIEP flaps and S-gap flaps. So this is the lady who's working on the microscope. Yeah. As I told you, the prosthetic dress which you can use. Yeah. So alloplastic reconstructions are done. That is the implant-based one, when the patient is not willing for any autogenous reconstructions. And we can be used, as I told you, there is if the mastectomy flaps needs an expansion, we can use a tissue expander, later replaced by an implant. We have a special types of implants. It's called as a Becker's implants, in which both the tissue expansion and the implant can be done at the same time. This is contraindicated in, as I told you, the radiation, the pre and post. And if the patient is having any wound healing issues, because it's a foreign material, so you have to be pretty sure about the wound healing status. This is a silicone implant. We have varieties of implants, varieties of shapes. And this is the most commonly we use a silicone implant. And as I told you, this is an expander, which we place it underneath it can be placed underneath the skin flap, or it can be placed underneath the muscle. It is there. As I told you, this is a port. If something like in deflated, it will come something like a very crumpled, deflated bag. We can create a small pocket, make a small incision. Through the small incision, you can create a pocket and insert the expander and keep it there, and we can slowly inflate it. Once after the suture removal, everything is done, maybe after 2 weeks down the line, we can start inflating up to the capacity, wait for 2 months, then remove the expander, you can place an implant. So in Indian scenario, most probably will go with an autologous reconstruction. Our perspective of implants is very less in malignancy. For non-malignancy, they will opt for implants, but not in a malignant condition. So, but in the Western scenario, it is entirely different. 70% of the women, they say that they're willing for an implant-based reconstruction. Yeah, a small thing about where we place an implant. We can have in subglandular, or we can place submuscular, or it can be a dual plane. So how we create an how we place an implant? This is already an incision being made. So we'll create a nice pocket. And you can see, can you appreciate this? The blue thing, this is the implant. And this is the cellular dermal matrix, which is being used in the lower pole of the implant. The main thing is that complication of implant is that in due course of time, there can be a capsule formation all around the implant leading to the capsular contraction. So that can be prevented if you use an cellular dermal matrix. Yeah, this is one of the technique in which after placing an implant, we are gonna, we'll just make a hammock, like a hammock, we just make it in a stitch so that it's gonna give the proper shape in the lower pole. So looking at her, everyone must have been aware of that. She got a bilateral prophylactic mastectomy done and an implant placed. So in 2013, I guess she was the talk of the world, I guess, because she was in BRCA was positive for her. And what are the complications of an implant? As in any sort of foreign materials, hematoma, seroma, infection is a common thing. The main thing is that they can have a deflation. There can be misplacement of the implant can happen. As I told you, the capsular contracture. Sometimes what happens is that the capsular contracture also, they can be calcified. So the rippling can be there and it will be easily palpable sometimes. So that is for the alloplastic reconstruction. Now coming to the autologous reconstruction, which we commonly do. That is the latissimus dorsi flap, which you should be well versed with that, because in case of you may not have a plastic surgeon, so you must have the knowledge that to raise a flap and do a reconstruction accordingly. Latissimus LD flap, it is most commonly it is used for a large variety of breast cancer defects. It can be used as in an immediate or delayed or an immediate reconstruction. It can be done alone or with an implant. Why I'm saying with implant? Because it doesn't give that much of bulk. The patient requires a bulk, then we can do a combination of flap with an implant. It is used for a small volume of breast. So whenever you do a flap, you should know your anat properly. If you know your anat, the dimensions of the flap which you can do, you can play with the surgery. So what are the indications is that, for suppose there is an insufficient abdominal skin, then you can go with an LD flap. If there is any previous abdominal scars, as I told you, prefer. And if there is any injury to the lateral thoracic region, where the neurovascular pedicle might be injured, so we can't take a risk of chance of going with the LD flap. This is the basic surgical anatomy of the LD flap. So it is a very pretty large flap, fan-shaped flap, which arises from the lower thoracic spine, posterior iliac spine, and the thoracolumbar fascia, and it forms the posterior axillary fold, and it attaches to the intertubercular groove of the humerus. So what is the main pedicle for that is the thoracodorsal artery. And he has the thoracodorsal nerve also being accompanied there. And yeah. So this is the subclavian system. The subclavian artery, it again gives us into the circumflex scapula and the thoracodorsal. So this thoracodorsal fellow, after coming down, it gives one more branch to the serratus anterior. So before piercing to the latissimus dorsi, it gives a branch to the serratus anterior. This thoracodorsal artery, it again divides into two branches. One, the vertical one, and an horizontal one. So mainly this vertical one will be on this lateral border of the lateral border of the muscle, and it have a very good perforators. As I told you, so this one is coming down, and it will give few branches from very good perforators, which will pierce the fascia, and it will supply a very good amount of skin. So based on it, we can Doppler that from the tip of the, approximately from the tip of the scapula, around some 8 to 10 centimeters from the down the line. You can mark it. You can get a perforator. Based on that, you can, as I told you, from the twig to the main, you can go from here. For suppose you found a perforator from here, you can trace it down till here. And based only on that, you can do a thoracodorsal artery perforator flap. This is one of the clinical picture showing this is the important point which you need to pay attention is that the vascular pedicles. Vascular pedicles mean what the neurovascular structure. This will be lying underneath the muscle. So while you are raising a flap, you have to be pretty careful because this area it will be okay. Once you come to this axillary area, you have to be careful with the pedicle. Once you damage the pedicle, then we have burned our flap. That's it. So this is the distracted posterior part of the LD muscle. As I told you, can see this vascular pedicle. So these are the thoracodorsal vessels. And as I told you, that the serratus anterior, and this is the scapular tip. So for suppose you are not doing a perforator flap, you are doing a normal routine LD flap. So what you need to do is the blood vessels, they come here, pierce through this muscle and supply this paddle of skin. So we have to, what I'm telling is that the vessel will come in this way. This is the direction in which you're going to take. The important point is that you have to have a very well area of your muscle. Muscle should be nicely there below your skin paddle. Look, this is the skin paddle, but look at the cut over here. If you use a large amount of muscle, then your skin flap is going to survive. The same principle happens, will be there for the PMMC, pectoralis major myocutaneous flap also. You should have an adequate muscle which is below your skin paddle. And the important tip is that when you're raising a flap, you have make a skin incision, something like that. As I told you, where we make mark of paddles, that is also tailor-made. It's not like, okay, I have to take it this way, this way. The only thing is that we have to have a vascular pedicle proper, and we should have the skin paddle should be on our muscle. That is the main dictum which we should follow. For suppose if there is a larger defect, means we have to come down. Means for suppose if a skin flap, we need such a bigger skin flap, then it is below the muscle. Then we have to go in such a way that it's going to be a random pattern. And this thing means if you're doing a 1:1 ratio of the flap here, it might survive. If you're taking a very more, if you're going till down to the lumbar, the business end is gonna get necrosed. So that you have to be careful. Even though the random pattern also you have to be careful. So as I told you, after raising the skin flap, make a skin incision, go down till your fascia. And once you reach your muscle, you make some stitches hitching the muscle with the fascia or muscle with this so that it doesn't shear off while you are handling the flap. It's the important step because what happens is that being an early budding surgeons, we might shear off this skin paddle. Then we are lost. We will be left only with the muscle in our hand. Okay. And the positioning of the patient is also very important. After the mastectomy done, we have to make the patient in a decubitus position with an hand abducted. Next one. Mundu better. Look here. Look here. They made a slant like that. They try to utilize the fat over here also. So this gives an additional bulk to the breast. Next. So once the pedicle is here right over the axilla, we can make a paddle somewhere in the higher up or lower up or back, or it can be an elliptical or based on the defect. For suppose there's a larger defect over here, we can use an VY. Just like in VY, we can mark our flap. So these are all the things which you can do after once you raise your flap and go till your dissect till your vascular pedicle. Next. So this is the clinical picture. As I told you, look, this is the skin paddle and it's lightly overlying the muscle. So through this, a small tunnel is being created and we just got it to the required area. Next. So there are various modifications for the LD flap. We can have an extended LD. We can have a muscle sparing. As I told you, we can go with the perforator based, or you can, as sir also was mentioned, you can go with the endoscopic LD flap harvest and microvascular. Microvascular means you have to identify till the thoracodorsal vessels, ligate the thoracodorsal vessels, and we can anastomose it with the internal mammary or internal mammary vessels. Next. Yeah. So this is the LD flap with an implant. Can you see the contour and almost all symmetrical? This thing. Yeah. Next. Yeah. This is all. That was all about the LD flap. Now coming to the tram. These are the abdominal flaps. The blood supply of the abdominal flaps. Previously, we have a transverse rectus abdominis muscle flap. Transverse means we are taking a bulk chunk of the tissue in the lower abdomen. What about the vascularity of this? The rectus muscle. We have the superior epigastric artery, and it comes here till the umbilicus. In here near the umbilicus, it will have a lot of anastomosis. There will be a lot of choke vessels anastomosing with the deep inferior epigastric vessels. So what we are doing in the traditional tram flap. Tram, we can have it in tram in two ways. One, we can have as a pedicled tram. Pedicled means there's a continuity is there. We're not detaching it completely. So we are detaching it at the pubic part, and we are ligating this deep inferior epigastric vessels, and we are lifting the rectus muscle along with your skin flap like that. I'll just get back to you in the pictures also to give an idea. This is the support. This is the skin flap, and this is the vessel. From here, again, the small twigs will come and supply your skin flap. So from here, we are cutting it here. We are raising the flap along with the skin flap, and we are using it to the reconstruction. We can use it for the same breast or into the opposite breast. And here, where the knot of the other abdominal flaps which we can use is that we can use an intercostal perforator flaps we can use, and here we can use something like a Rubens flap, that is the superficial circumflex iliac artery flap. So this will be very thin flap which we can use, or most commonly free flap which we microvascular flap which we use is the deep inferior epigastric vessel flap. And this is the basic anatomy of from where the rectus abdominis rectus muscle is being attached, the pubic symphysis to the xiphoid process, but also from the costal cartilages, and it's covered on by the rectus sheaths, as I told you, supplied by the superior epigastric muscles. So after the mastectomy being done, we will take a lint. Lint means in the sense it can be a cloth or a gauze based on the defect. We'll just place it on the mastectomy defect and we'll cut our pattern. So that pattern will reimpose on our the area which we are being planned to get a flap done. So suppose we are taking this muscle, this side we are taking. There will be a lot of periumbilical perforators which we need to be included. So our flap should be included in our periumbilical perforators also. We'll make a superficial dissection to create a skin paddle, skin and subcutaneous tissue. And then we'll go to the intramuscular dissection, separate the perforators, and the submuscular dissection, the ligate the deep inferior epigastric vessels, and we had to lift the tram flap. So look, here they're taking the vessels based on so this one, the rectus one. So they have, you can see how beautifully the vessels are coming from the rectus, and also they're supplying to the skin. So we have to preserve all so the blood supply will be based on this. As I told you, this will be your perforators, which is supplying your skin pad. Next. So this is one of the clinical picture showing after raising a flap, we have marked a flap, something like that. And after making an incision, the skin paddle incision, and we are ligating the deep inferior, and we are raising the skin flap. So from here, it's going to the contralateral side. As I told you, we can switch and go to the contralateral or ipsilateral. Ipsilateral will be preferred because I'll come back to you. There will be, we have 4 zones over here, over this lower abdomen. The one which is supplied on the right at the rectus will be a zone 1. The opposite will be a zone 2. This is going to be a zone 3, and this is going to be a zone 4. So if you're taking a flap like this, based on this, and if you're using for the ipsilateral, then what happens is that the more vascularized part, zone 2 and zone 2 will come over, zone 2 and 3 will be used, and 4 we can be discarded. Next. So as I told you, you can switch. Next. So this is one of the clinical pictures showing the skin paddle. It's been deepithelialized in order to give the volume to the breast, and this below one is the rectus muscle, and this is the outcome which is being done. And the advantage is that it will be something like in tummy tuck, and we had to create a neo umbilicus for the patient, and a concealed scar in the lower abdomen. And the donor area, sometimes it depends, there will be a lot of varieties of in the tram also. If you're doing a muscle sparing, then you can close it, or we have to use a mesh also for the closure of the defect, because the chance of abdominal wall hernias and bulges will be there. As I told you, there will be simultaneous abdominoplasty being done, concealed scar, and yeah, the same thing which is being done. The modifications are the muscle sparing, and you can do a delay. Next. As I told you, if you're taking this, the superior epigastric of this, the rectus, it's going to be a zone 1. This is going to be a zone 2, the opposite contralateral rectus side, and this is going to be a zone 3 and 4. 4 will be the very least perfused area. So, previous bit. So, as I told you, zone 1 is very, perfusion will be very maximum, so that we can safely use it as an pedicled one. Zone 1 and 3. Previously, they thought that zone 1 and 3 are very good. I mean, 3 is having a good perfusion, but recent studies says that zone 1 and 2 are having a good perfusion compared to 3. 2 has a better perfusion, and 4 we mostly will discard it because the perfusion will not be that great. What is the impact of abdominal wall when you take a muscle flaps? I mean the tram flaps. If we have a pedicle, you are taking an entire muscle, obviously there is going to be a lot of abdominal wall defects are there. We need to cover with a mesh, and the chance of hernias will be more. And coming to the other end is going to be a deep inferior epigastric and superficial inferior epigastric, where we're not going to touch the muscle. We are just only the splitting the muscle, enter into the dissect the vessel, go to the pedicle, and we are going to get it. So we are not going to do any damage to the muscle. So the chance of the abdominal wall bulges or hernias are very less here compared to the conventional tram. Next. DIEP flap, deep inferior epigastric flap. As I told you, it's mostly the most common flap which we use for reconstruction nowadays because it get an adequate volume is there and because of the advances with the microvascular reconstructions. This is the deep inferior epigastric artery perforator based. The same way, we make an incision. Look, this is the skin paddle which we mark after doing a planning. Planning means we just put a lint over the mastectomy side. We just get back to that our area and we'll mark our flap accordingly. And we had, while important thing is that while doing a match, while assessing the defect itself, we should see that contralateral breast and see that, okay, which pole of the breast has a larger volume. And we need to plan here accordingly. Next. This is the demonstration of how we take it. Look, we are comparing it with the opposite side. All the markings are very important. We have to mark the midline, the inframammary thing, inframammary fold, where the normally the nipple should be there. These are all the things which we needs to be assessed priorly. Even here, look, this is the skin flap which we mark, and this is the extra fat which we are taking it to fill the superior pole. In order to, this fullness is very difficult to achieve. So we dissected it. Look, can you see this? This is the perforator which is going down. So we have to dissect it till down. Can you see how long we got the perforator? Next. So once we get the perforator, we are going to put a clamp. We are totally detached the flap from the body. And after that, it's going to be a two-team approach. One team will be dissecting for the recipient vessels, another with recipient vessels mostly in the internal mammary, in the breast area, and others will be dissecting for the flap. So after we place the flap over the recipient, the recipient breast area, and we'll do the microsurgery. Next. If you don't find internal mammary, you can go with the thoracodorsal vessels. And this is the anastomosis. You just plate it. We'll put some few sutures so that the flap is not hanging down, and we'll complete the anastomosis. This is the anastomosis which is done for the vessels. Next. This is the final outcome. Next. So, as I told you, the complications can be anticipated. Apart from because it's going to be a long procedure, the chance of DVT is there, so we have to take proper care. And as any flap, the chance of failure is there. The flap or the chance of flap necrosis is there, and the wound breakdown. As I told you, the hernias and bulges can be anticipated, but it's not as compared to the conventional tram. In DIP, it's going to be less. The other things is that the superior gastric artery perforator flap or superior gluteal artery and inferior gluteal artery perforator flaps. So if the abdominal fat is less, then you can go with the glutes. So this is the superior gluteal artery flap. So we will draw a line from the posterior superior iliac spine to the greater trochanter, and the perforators will be somewhere in between the upper and the middle third, and you can raise around some 8 to 10 centimeter of the flap can be harvested, and we can use for the microvascular free. Yeah, this is for the inferior. The same way above, we can even use it for the below. Everything will be a concealed scars. Complications as usual. Yeah. So we reconstructed a breast mount is being achieved. So what is the next step is that to create a nipple areolar complex. So it is a purely cosmetic procedures and it can be done as a daycare procedure. It is done 3 to 6 months after your reconstruction. Once the breast is well settled, then we can go with the NSC reconstruction. The most common things which you use for nipple reconstruction, we can use the local flaps which have been commonly done, and nipple sharing is rarely done. And areola, we can use a skin grafting for the areola which is all around the nipple. In order to have a matching of the skin, we can use a skin from the inner thigh, and we can use a professional tattooing, which is a 3D professional tattooing, which will mimic that the areola on the nipple. And we can have a prosthetic, just a stickies, which we can use for the nipple. As I told you, the tattooing is all a professional tattooing which is done for the areola. Next. So nipple reconstruction is something like an origami work which we do for the paper thing. So we already got in skin. The breast mount is there. So we can have a varieties of patterns of skin flaps are there. Based on that, we can adjust and we can make a nipple out of it. So we have a skate flap, CV star, fishtail. So it is all the surgeon's comfort, how we are trained and how we can do. So just look, they make an incision, something like that. And to get in bulge, look at the thickness over here and the suture. Something like you can get it done under local anesthesia. It's a skate flap. So this is a star flap. You can make in 3 flaps raised and sutured like a criss-cross so that you can get a nipple. The one more important topic and the recent advance which has been happening is that the post-mastectomy lymphedema. For the mild cases, we can use something like stockings or compression garments or hand elevation. We can go with the conservative management. But what to do if there's a lot of edema is happening in the hand? Now, in our scenario, the lymphedema mostly we'll have in filarial leg lymphedema. For that only we are addressing in India because of our endemic and all. In the Western side, they're using something called the vascularized lymph node transfer. In that, they're taking a lymph node along with the blood cell, with the skin paddle, with the lymph node, with the blood vessels. They're going to take it, can be from supraclavicular or the groin node. They're taking it and they're putting it over the arm so that the lymphatic drainage, because already we are doing a node dissection, we are adding the lymph node. This is the recent advances which been started in India. In Western countries, along with the mastectomy, nowadays even they're doing even the free lymph node transfer also being there. So in future days, even we will also be able to tackle the lymphedema with the free lymph node transfer. So as I told you, the contralateral breast, they can be done a reduction mammoplasty, mastopexy, augmentation, or a prophylactic mastectomy as for the BRCA1. And these are all the things which can be offered to the breast, offered to the opposite breast, but it's all the patient's choice. Yeah, take home is that let the patient be aware of all the options available. Let her get the best one. And as I told you, it's a multidisciplinary approach. And the main motto is that to have and provide a very good quality of life. Thank you.
Anybody, any doubts? Can please clarify.
Yes. That is only because of the rectus only, sir. Rectus is there. I mean, clinically, I'm telling you, over the rectus, the skin over the rectus. I mean, suppose it's the midline. This is the midline. We have the rectus immediately next to the midline. So that will be a zone 1. Then adjacent to that rectus will be the other zone. So this contralateral will be a zone 2. And for the DIEP flaps, we do an CT angio. We preoperatively will mark the perforators. For the DIEP, we have 2 rows of perforators will be there. We have a medial row and a lateral row. We should trace out for a very good caliber of perforators. Based on that only we will do. Normally in our setup, we'll do a handheld Doppler, a color Doppler for the perforators. But in the higher centers and in the Western side, they are doing a CT angio to trace out for the perforators preoperatively.
You said that continuation for this question. You said that in the zone 4 we discard that zone 4. Then why do you need then to remove
for closure, sir?
That's simply
obviously for closure. Even though if you take up half of the people are there who will do in half thing also, but for closure it will be difficult. So something like an abdominoplasty we are doing it. But important thing is that while rising your flap, we have to be careful because already we have taken compromise the skin over the lower part. Even in the midline also, we are compromising. So the perforation will come from the lateral side. So that is that thing you have to be careful. Otherwise, you're gonna get a skin necrosis, skin issues at the suture.
Thank you. I'd like to request Dr. Suhas Chaitanya, sir, our associate professor, to present a memento to our speaker, and Dr. Zarina ma'am, senior resident, to honor our speaker with a shawl. Thank you, sir. Thank you, ma'am. To conclude our morning session, I'd like to request our HOD, Dr. Mahinda Reddy, sir, to come out to the dais.
Yes, so we had a very wonderful CME session. See, mainly we selected this topic of recent advances because postgraduates, one among your 4 papers which you will be writing in your university examination, one is exclusive on recent advances. So that is one reason we thought of having this particular topic. So we had wonderful sessions starting with the recent advances in surgery, then we had recent advances in radiotherapy, then chemotherapy, and finally on a conclusive note, about discussion on different types of flaps and other things. So with this, we conclude this session. I thank all the speakers. Again, within a very short notice, they have responded and they came leaving aside their clinical work. So a big thanks to all of them. So I request everyone to clap for them. Yes. So now before we break for lunch, we'll have the faculty and speakers will have a photograph. After that, the participants will join us for one more photo, then we'll break for lunch. And again, like Harish sir has put a message in the group, the postgraduate has to stay back for some pre-test for afternoon session. Okay, so now I request our faculty and the speakers to come for a group photograph. See, faculty are requested to come for a photograph. Please come. You can have a photograph with speakers. Then we'll break for lunch. Surgery faculty will stay back because everyone will not cover in the photograph. PGs, come here. So PGs, please. Yeah. కొందరు పడుకున్న ఉన్న వెనక్కి వెళ్ళిపోండి ఇప్పుడు see Anvesh Prajit, I think you can stand in the third row. 3 rows, I think. Answer. So we'll break for lunch. PG, stay back. So after 10-15 minutes, you can join. There is a pre-test for you. So now I request Dr. Harish to conduct the pre-test. So faculty and speakers will go for lunch.
అందరి దగ్గర మొబైల్స్ ఉన్నాయి కదా, అందరు ఇక్కడే ఉన్నారు కదా, కూర్చోండి కూర్చోండి. ఎవరెవరు లేరు? ఎవరు లేరు? 1 2 3 4 5 6 7 8 9 10 12 13 14 15 16 17 ఓకే. ఉన్నారు కదా, సెకండ్ ఇయర్స్ అందరూ ఉన్నారు కదా, రైట్. సో విల్ బి గివింగ్ 10 minutes 20 క్వశ్చన్స్ ఉంటాయి ప్రీ టెస్ట్ లో. సో 10 minutes టైం ఉంటుంది. డోంట్ టాక్. సపరేట్ గా మీరు ఇండివిజువల్ గా మీరు ఆన్సర్ చేసేసేయండి. ఇట్ డజంట్ టేక్ మోర్ దాన్ 10 minutes. టకటగా ఆన్సర్ చేయండి. మీ నేమ్ అండ్ విచ్ ఇయర్, ఫైనల్ ఇయర్ సెకండ్, అదే ఫస్ట్ ఇయర్ అని పెట్టండి, నాకు కన్ఫ్యూజన్ వస్తుంది. మీరందరూ ఫస్ట్ ఇయర్ అని పెట్టండి, మీరందరూ ఫైనల్ ఇయర్ అని పెట్టండి. ఓకే, నన్ను పెట్టేసి మీరు ఈ క్వశ్చన్స్ ని ఆన్సర్ చేసేసి నాకు పంపించండి. ఐఎమ్ జస్ట్ పోస్టింగ్ ఇట్ ఇన్ గ్రూప్. ద టైమ్ ఈస్ 2 o'clock కరెక్ట్లీ రైట్ నౌ. అండ్ చేసేయండి. ద లింక్ వచ్చింది మీ అందరికి ప్రీ టెస్ట్. సో యూ ఓపెన్ ఇట్ అండ్ యూ డూ ఇట్. Do not talk to each other. You just do on your own. A sensor. Yeah. Five more minutes. Last minute. Six responses వచ్చేసాయి ఆల్రెడీ. ఎవరెవరు కంప్లీట్ చేశారు? Get up. Submitted for that. Those who have submitted can come out. Yes, time up. అందరు సబ్మిట్ చేసేయండి. 5 minutes ఇవ్వాలా? కానీ రెహమాన్ సబ్మిట్ చేసావా? శివ సబ్మిటెడా? శృతి సబ్మిటెడా? 2 minutes అట్లా ఇస్తాం. 10 minutes క్వశ్చన్ పేపర్కి సబ్మిటెడ్ కదా. పదండి, భరత్ పద, రవికిరణ్ పద. మెయిల్ అడ్రస్ ఫస్ట్ ఉంది, అవసరం లేదు. నువ్వు సబ్మిట్ కొట్టావా లేదా? అయిపోయింది సార్. 19 responses till now. Okay. Vagalakshmi, Ravikiran, Tejasvi. అయిపోయింది. మీకు పేర్లు చదువుతున్నా, అయిపోయిన వాళ్ళు పేర్లు చదువుతున్నా అంతే. భువన, వైష్ణవి, శివ పద వెనక్కి నేను దూకు. ప్రశాంత్ అయిపోయింది. రెహమాన్, అన్వేష్ రెడ్డి, మోనిక, వెంకటేష్, సమీర్, పావని పదనమ్మా. సబ్మిటెడా? సబ్మిట్ చేశారు కదా. లక్ష్మి సబ్మిట్ చేయమ్మా, సబ్మిట్ చేయి. అయిపోయింది, టైం అయిపోయింది. I have given you 1 more minute also. 31 responses, still 4 responses remain. అయిపోయిందమ్మా, సబ్మిట్ చేశారు పదండి. రవీంద్ర సబ్మిటెడా? సబ్మిట్ చేయి. Ready to 3 more. Lakshmi, okay. Ravindra, Anand. ఎవరు చేశారు అంటే ఫస్ట్ నేమ్ అందరికి పెట్టేసారు. ఫస్ట్ క్వశ్చన్ నేమ్ ఆఫ్ ద క్యాండిడేట్. సో ఆన్సర్లు 33 రవీంద్ర. వస్తే కన్సిడర్ చేస్తాను సార్. వీళ్ళలో కనుక ముందు వచ్చి ఇంక వేరే వాళ్ళు వస్తే వీళ్ళు ముగ్గురిది అంటే బ్రేక్ అన్నీ తీసుకోవాలి. ఉంది సార్ రెస్పాన్సెస్. ఆనంద్ నీ పేరు పెట్టావా లేదా? ఏమన్నాను సార్ నువ్వు? 34. లక్ష్మి నువ్వు ఇంకా సబ్మిట్ చేయి. 35 వచ్చాయి.